Okay, good evening to all. Uh, First thing I would like to say is congrats to all who have cleared theory. So I think that is the first big barrier that you have cleared. So the second is the practicals. So that is not going to be as hard as theory, but you need to have a systematic approach in all of the stations that are there for the practical exams to clear. So that's where we are there to help. So my talk today will be on five areas. One is on critical appraisal. The second is on quality indicators, ECGs, BLS and ACLS, and last is focus. So I'll cover first on the two most dry topics. That's the driest topics, that is critical appraisal and quality indicators. Then we'll go on to the more interactive sessions so that you don't get lost. So first I'll be discussing on critical appraisal of a research paper. That is how you need to go about it. What are the things that they are going to ask in the exam and what you need to answer also. So these are the main areas that I will be covering, and I've made it as simplified as possible so that it will be easy for you to go through this and answer in the exams. So the main areas that I'll be covering are introduction and then how to analyze a research paper. So why is critical appraisal important? So it is essential because you need to do critical appraisal to avoid blindly accepting published results or data, to identify bias and limitations, and to determine whether a study should change clinical practice or merely inform future research. So let us take a small example. We have a doctor 123. He reads a RCT reporting benefit of a new drug over a placebo. The authors recommend it as a first line therapy. So, without critically appraising the methodology, the magnitude of benefit, or the applicability, he adopts it into routine practice. So, few months later, he was called to the medical director's office. So, an analysis of prescribing costs in this department showed his costs were much higher than his colleagues without better results. So, despite statistically significant results, the intervention failed to show real world benefit due to methodological limitations and poor applicability. So, this is why critical appraisal is important. So, the main areas I will be covering here is the concept of evidence based medicine. Why do we need to critically analyze, and the elements of a critical appraisal? So, the concept of evidence based medicine is the evidence based medicine is the integration of the best available research evidence, the clinical expertise, and patient values. So, all these need to be combined to make informed clinical decisions. So, evidence alone is insufficient without appraisal. So, what are the components of evidence based medicine? There are five steps. One is question, evidence, critically appraise it, application, and monitoring. So these are the main areas in relation to evidence-based medicine. And the area that we will be covering is only on the critical appraisal. That is to evaluate the evidence, critically appraise the evidence for its validity, impact, and applicability. So what is this appraisal? It is an act of assessing something or someone. That is the basic meaning of it. So why do we need to do this critical appraisal? One, to detect bias and systematic error, to assess the magnitude, not just the significance of results, and to determine whether the results are applicable to my patients. All right. So this is the main core of critically analyzing a study. So to make it systematic and understandable, there are five elements of an appraisal. One is, what is the research question? Two, is the study design appropriate for this question? Three, is the study internally? Four, what are the results and how meaningful are they? Five, can the results be applied to my clinical setting? So coming to the first question, what is the research question? Usually when you read RCT or a research paper, it will be given at the end of the introduction section. So it can be organized with the help of the Picot format. So what is Picot? P stands for population or the problem. That is the population characteristics or health issue of interest. Intervention or exposure is I, where it can be a drug, surgery, policy. C is a comparison, where there can be it's like a placebo, or there can be another drug. And O is the outcome, that is the health outcome of interest. And T is the time frame, that is what is the time period for the intervention to achieve its outcome. So many a times they also do mention about secondary outcomes. If it is there, you need to mention about that also. So the research question in the study needs to be formatted in the form of a Picot. So when you get the research study in your hand, the first thing is to assess the Picot. Please do not blindly read the abstract. Go through the details and make notes of it as soon as possible. Then what is the design of the study? So the basic norm is, the higher the quality of evidence and lower the risk of bias, the better the validity and applicability of the study to the general population. So this is the general norm. So you know about this pyramid. At the top of the pyramid is the systematic reviews and meta-analysis. Then comes the RCTs. For the exam purposes, RCTs will be the ones that will be most commonly kept. So as you can see, from lower to upper or from lower to higher, the quality of evidence increases. And as you go from higher to low, the risk of bias increases. So that is the importance of this pyramid. So the choice of study design must align with the research question. So if it is for therapy purpose, then an RCT is the ideal one. If it is for diagnosis, then a prospective cohort or a cross-sectional study is the ideal one. The important thing you need to keep in mind is, a poorly conducted study, even with an appropriate design, may overestimate treatment effects. So the next question is to assess the study's validity. So internal validity refers to whether the study was conducted in a manner that ensures the observed results are true for the study population rather than due to bias or confounding. So the next important step of your appraisal is to search for bias. So what is bias? Bias are mistakes not occurring due to chance, but due to mistakes in the research study. So it leads to erroneous conclusions as it results in differences between groups that are not simply due to chance or the exposure of interest. So when interventions are applied based on these conclusions, it can lead to harming patients. So that is why it is important to look for biases in your study. So like I said, bias overestimates the effects. So bias affects the validity, not the precision. So the types of bias and the ways it can be avoided. So the first and the foremost is the sampling bias or the selection bias. So selection bias occurs when study participants are not representative of the target population, commonly due to non-random allocation. Many a times, volunteering subjects may be taken into the study, but they may not represent the study population. most commonly seen with case control studies and retrospective cohort studies, and it can be avoided by randomization. And in that, they say stratified random sampling is considered to be the best. So the absence of randomization increases the risk of selection bias, thereby affecting the internal validity. Then we have something called the recall bias. So recall bias occurs when participants inaccurately remember past events, especially in retrospective studies. So it can be minimized or avoided by minimizing the time lapse between the event and data collection, and use of objective measures whenever possible rather than using subjective measures. So if subjective measures are used rather than objective measures, or increased time between data collection, then there is an increased risk of bias due to recall bias. All right. So in the study, during the initial study design, if you see that they will use subjective methods to analyze the data or to collect the data, then you have to have it in the back of the mind that there is a risk of internal validity being affected. Then you have something called the observer or the Hawthorne bias. So Hawthorne bias refers to alteration in behavior due to awareness of being observed, potentially limiting generalizability. So the best example is in a classroom of students. So they would be writing an exam, on in between they may be chit chatting, like trying to get answers. So as long as they are not disturbed, they may be copying whatever is being told, and that may affect the results at the end. But if there is a supervisor in the exam who's constantly monitoring them, then the behavior will be different, and that will affect the outcomes at the end. So this is the simple example that I had for this Hawthorne bias. So it refers to the alteration in behavior due to awareness of being observed, potentially limiting generalizability. So the importance is it may threaten generalizability to the general population, and it can be avoided by single binding. So in your study, check if single blinding has been done in the study protocol. If not, there is an increased risk of bias. Then interviewer or expectancy bias. It occurs when the investigator's knowledge of the group allocation influences assessment. So that can be avoided by double blinding. So check if double blinding has been done. If not, it can lead to increased risk of bias. Proficiency bias. So variation in skill or technique among investigators can influence outcomes. So pilot studies and standardization of intervention can reduce this bias. So when you look through the study protocol, check if a pilot study has been done. If it has been done, then the internal validity in relation to the risk of interventional bias is likely to be less. So assess if the previous pilot study performed for an interventional study and if minimal number of personnel perform the intervention. So if both of these are not there, then there is an increased risk of bias due to proficiency bias. Then you have transfer bias or attrition bias. So unequal loss to follow up between groups can distort results. So it is seen in per protocol analysis. Usually intention to treat analysis usually preserves this randomization and reduces this attrition bias. So in your study, assess if intention to treat analysis is there. If it is not there and they mention about poor protocol analysis, then that can increase the risk of bias. So for summary, bias during the study design, you can have sampling or selection bias. So you look for this by assess if sampling has been done and if it is a stratified random sampling. Then bias during the clinical trial. So you need to assess for 6 biases. One is the observer or Hawthorne bias. So you assess if there is single blinding which is done. Interviewer bias, assess if double blinding has been mentioned. Recall bias, assess if objective measures have been used in the study or the time duration between the data collection and the patient subjective details are very minimal. So that needs to be looked into. Then interventional bias, assess if pilot study is done and minimal people perform the intervention. Exclusion bias, assess if intention to treat or protocol analysis is done. If poor protocol analysis is done, there is an increased risk of this exclusion or attrition bias. And transfer bias, assess for homogeneity in distribution between the cases and controls. So these will be the total 7 things that you need to look into when you assess for bias. So many a times there will be a question that will be asked. Is bias and confounding the same? No, both are not the same. Bias is a systematic error in how the study is conducted, whereas confounding is distortion due to a third variable linked to exposure and outcome. Example, ICU mortality lower with drug X, but drug X group had younger patients. So that could be a confounding factor. So this is about the internal validity assessment. So you need to look into bias. And the next thing is you need to know that bias and confounding are not the same. Then you assess for the study's results. So you have descriptive statistics and comparative or inferential statistics. So in descriptive statistics, you see who are in the study, and in comparative, you see how the groups were compared. All right. So one of the most important areas that you need to look into is the sample size and the power of the study. So the sample size is how many people you studied, and power is how likely you are to detect a real difference if it truly exists. So these are the two things you need to look into. So sample size, I'm explaining this with examples so that you get a better clarity. So you have a study question. Does drug A reduce ICU mortality compared to placebo? So the true situation is not known to researchers, but there were previous observational studies where they showed that placebo mortality was around 20%, but drug A mortality was 10%. So the true absolute reduction rate was 10%. That is 20 minus 10, that is 10%. So why the sample size takes real importance is, you see the scenario 1 where less number of patients were taken in the study. That is total 40 patients, placebo had 20 and drug had 20. So based on this mortality assessment, they found that the deaths were 4 and here the deaths were 2. But the ultimate p-value was 0.38. So the study failed to detect a difference not because the drug doesn't work, but because few patients were studied. Similarly, in scenario 2, here you see that they've taken 200 patients. That is, placebo had 100 and drug A had 100. Here the deaths were 20, whereas in drug A it was 10. So here you see that the p-value is significant. So the study detected the true effect because it had enough power. All right. So this is why the sample size is very important. But many a times there is always a question: what is the sample size which is considered adequate? Especially when I had done my DRNB, during my practical preparations, I always had a doubt as to which sample size is the correct number. So having discussed with many people and reading through articles, one thing I'd come to a conclusion was there is no single adequate sample size. Adequacy depends on what difference you want to detect and how sure you want to be. So here the examiners are testing whether you understand the logic. So a sample size is adequate if it is large enough to detect a clinically important difference with an acceptable certainty, that is power, while keeping the false positives low. So the four things that decide adequate are: one is the expected effect size. So what is this effect size? It is how big a benefit the researchers are expected to have following the treatment being given to the patient. So this expected effect size means how big a difference you want to detect. If you want to detect a smaller effect, then you need a larger sample size. Then the baseline event rate, that is how common the outcome is. So if you have a rare event, then you need a larger sample size. Then power, that is the chance of detecting a true effect. For a higher power, you need a larger sample size. And for alpha, that is the p-value cutoff, it is meant to assess the chance of false positives. If you have a stricter alpha, that is you keep the p-value cutoff at 0.05, then for that you need a larger sample size to detect a positive or a truly negative outcome without any false positives or false negatives. So what is this big effect and small effect? So just I wanted to clarify that. So for the big effect, you tested drug A versus placebo, you see that the mortality drops from 40 to 20%. So the difference is pretty obvious. So a small study itself can detect it. But a small effect size is the mortality drops only from 20 to 18%. This difference is subtle. So to show this subtle difference, you will need more number of patients. So big gap between groups is easy to see, but tiny gap between groups is hard to see unless you zoom out. So that means you need more patients. So this is the easiest analogy to understand the importance of sample size. So just for a better understanding, there are four important things that you need to look into to mention adequate sample size. One is the expected effect size, the baseline event rate, the power, and the alpha. That is the p-value cutoff. So then coming to the power of the study. So the power is the probability that a study will detect a true difference when one actually exists. So 80% power is acceptable, 90% power is ideal. So the factors that need to be considered while you look into the power of the study is the sample size. Like I said, but the more the power of the study, the larger the sample size you will recover. So what it means is more patients, so that is equal to less chance that the results are due to luck. The simple example is with 20 patients, 4 versus 2 deaths may be by chance, but with 200 patients, the same difference is more convincing. Then bigger effect size. A larger difference between groups is easier to detect. Like I said, mortality drop from 40 to 20% is obvious, but a drop from 20 to 18% is subtle and needs many more patients. Less variability. Outcomes are more consistent across patients. So ICU stay of 5 to 7 days in most patients is low variability. It is more easier to compare than 2 to 30 days there, which shows a high variability. Then a higher alpha, that is a P of cutoff. That is being more lenient about calling a result significant. So using P value of less than 0.1 instead of 0.05 makes it easier to label a result as significant, but the problem is it can lead to increased false positives. So these are the four areas that you need to look into when you look into the power of the study. So like I said, in sample and in power of the study, you always remember the 4 points that you need to look into. So again, I'm just emphasizing this for the sample expected effect size, baseline event rate, power, and alpha. And for the power, you need to look into the sample size, the effect size, variability, and alpha. So both are almost having the same similar parameters. So you don't need to remember the formulas for the exam because the examiners who are going to be there are not statisticians. But you need to understand the concepts in relation to this so that you can justify whether the sample size was adequate, whether the power is adequate, whether this will have a good precision on the study. Then coming to p-value. So p-value of less than 0.05 indicates that they're statistically significant alone. It does not mean that statistical significance is equal to clinical significance. So example, in a data set, there may be statistically significant association between patients whose name begins with A and death due to myocardial infarction, but it has no clinical significance. Then coming to standard deviations. So many times when you look into the data tables, many times they write about SDs and all that and confidence intervals. So to understand the confidence intervals, you need to know a little about the standard deviation. So mean is sum of all values divided by the total number of values. Then variance is dispersion of values around the mean. So it is the sum of difference of all values and the mean divided by the total number of observations minus 1. Standard deviation explains how much values are scattered around the mean. So it is the square root of variance. The importance is the extent of the bell shape of normal distribution depends on the standard deviation. So the larger the standard deviation, the greater the spread. So here you can see, you can classify it as 1 standard deviation, 2 standard deviation, and 3 standard deviation. Actually, 2 standard deviation is what is taken in most of the studies where it includes 95% of data, that is confidence interval of 95%. And 3 standard deviations is around 99%, and 1 standard deviation is only 68.3% of the data. So coming to confidence intervals or confidence limits. So confidence intervals describe the range and precision of the estimated effect. So narrow intervals indicate greater precision and reliability. For example, 95% confidence interval is a range of values that you can be 95% certain contains the true mean of the population. As the sample size increases, the range will narrow and the precision increases. So while interpreting confidence intervals, if the narrow confidence intervals are far from the zero, then you can be confident and the result is supposed to be good. Whereas if the confidence intervals are wide, crossing the zero, then it is highly uncertain and it does not change your practice because it is going to be insignificant. So clinically meaningful effects should lie entirely within the confidence intervals. So which is better, p-value or confidence intervals? So both can indicate statistical significance. The p-value provides a measure of the strength of an association, whereas the confidence interval indicates the magnitude of an effect and likely implications because it indicates a range of possible values for the true effect in the target population. Simple to say, confidence intervals tell how big, how certain, and whether that matters. Whereas p-value tells only if something exists. That is, something significant exists. So next important term you need to know is about the number needed to treat. So the number needed to treat represents the number of patients who must receive an intervention for one additional patient to benefit. So lower the NNT, greater the clinical usefulness. So again for this also, if it is as low as 1, then it is supposed to be a very, very good outcome. Whereas if it is very high, like if it goes into 2-digit or 3-digit, then the number needed to treat shows that the intervention is not likely to be very beneficial. But that needs to be compared with other interventions also, that is based on other studies. So this is just a tabular formulation of all the parameters that are usually mentioned in the studies related to an RCT. So you need to know about this in the exam because these will be the ones that can be asked. So I have discussed about mean. Relative risk is how likely an event is in treatment versus control. So the risk in treatment divided by the risk in control. That is, deaths due to drug A is by 10 by 100, that is 10%, whereas placebo is around 20%. Then the relative risk is 10% by 20%, that is 0.5. So what do you tell in the exams is patients on drug A had half the risk compared to control. So that is the way you need to interpret the relative risk. Whereas the absolute risk reduction is the actual differences in outcomes. That is the real patient benefit. So ARR is equal to the risk in control minus the risk in the treatment. So 20 minus 10 is equal to 10%. That is 10 extra lives saved per 100 treated. So ARR reflects the true clinical benefit. So that is one thing you need to keep in mind. Then coming to the number needed to treat, the formula for this number needed to treat is one thing you need to keep in mind. It is 1 by the absolute risk reduction. Then you have confidence intervals, which I had discussed, the range within which the true effect is likely to lie. So the point estimate plus or minus the margin of error. So the true benefit likely lies between 4 and 16%. So this is how they usually mention it in the tables. So when they ask you in relation to that, you will need to mention it like this. So just a simplified understanding of what I just told. Mean is what happens on an average. Relative risk is how dramatic the comparison sounds. Absolute risk reduction is how many patients actually benefit. Number needed to treat is the effort needed for one success. And confidence interval is how sure we are all about this. So if relative risk alone is there, that alone, if it is there, it can look impressive even when the benefit is small. But when absolute risk reduction, number needed to treat, and confidence intervals are mentioned, these three decide whether the practice should change. That is why you need to know about these parameters. Then, once you have assessed the descriptive and analytical statistics, then you assess the study's applicability. So, to what extent the research methods used by the researcher have been good enough to answer the clinical question. That is also called as internal validity. If the study has poor internal validity, we may have unrealistic expectations of the outcomes. So this was what I had explained during the bias talk. So to what extent can the results from the study be generalized to a wider population? That is also called as external validity. So we need to know whether we will get the same results in real life settings. So this is what we also need to look into. So for this, we need to see if the study population is similar to that of what we have. Then towards the end of the study, they usually mention about the funding source and the conflicts of interest. So why this matters is industrial funding correlates with positive outcomes most of the time. So what you need to check is whether it is industry sponsored, if there are author affiliations or drug manufacturers involved. Funding per se does not invalidate results, but it raises the bar for suspicion. So if this funding terminologies are there, then you need to look little more in depth into the content because there is a potential for bias. So, like I said, for external validity, do the subject study look like my patients? And the next thing is, does the outcome really matter? So this is where the decide phase comes. And in the exam, this is what the examiners want to listen to. Do the results matter clinically? Yes, mortality reduction is clinically important. Then the external validity. If they mentioned a single center study with better nurse patient ratio than our ICU, then it limits generalizability because looking practically in most Indian ICUs, the nurse to bed ratio is usually one is to like one nurse takes care of two beds or three beds in many places. So that may affect the generalizability. Then conflicts of interest. Study funded by drug A manufacturer. So judgment, funding does not invalidate results, but it warrants cautious interpretation because there is a potential for bias. And impact on practice today. This study alone is insufficient to change practice immediately. So that you need to assess based on the true understanding of the study. You need to look into the study's internal validity and make a decision on that. Then the decision based on all that you've looked into, that is, you looked into the PICOT, then you looked into the biases, then you looked into the analysis, data analysis, you looked into the study population, then you looked into all the data, and then you come to a final conclusion. Then you see whether there is a benefit in using it in your subset of patients, or whether you are going to use it or discard the study or wait for any guidelines and come to a decision. So that is the point where evidence, if it is needed next. So I would wait for a multi-center RCT or guideline recommendations before adapting this therapy. So this is about the decide component. So this is the story I told. Dr. 123 reads an RCT reporting benefit of a new drug over placebo. The author recommends it as first-line therapy without critically appraising its methodology, magnitude of benefit, and applicability. He adopts it into routine practice. Few months later, he is called to the director's office. An analysis of prescribing costs in his department showed his costs were much higher than his colleagues without producing better results. So despite statistically significant results, the intervention failed to show real-world benefit due to methodological limitations and poor applicability. So this emphasizes the importance of critical appraisal before changing practice. So if you are using your tablets and your laptops, please take a snapshot of this. This is the format that you need to keep in mind when you read through the paper which is given to you in the exam. All right. So, like I said, the PICO format, then you need to look into the sample size and the power calculation. I told you, you need to look into the 4 parameters. Then the allocation, that is this randomization, stratification, look for confounders, then the blinding process, then the follow-up of participants, that is intentional to treat, data collection process, how it was done, then the presentation of results and applicability to local population. Then you make up towards the end, you just write it by yourself. Do the results matter clinically? You read the study and see if it is so. You assess the external validity, whether this subset of patients that were studied are similar to the ones you normally encounter in your ICU. The conflicts of interest, whether there was funding done or not, or whether it was a drug manufacturer who actually sponsored the study, whether it will have an impact on your practice today, and your decision whether you want to change your study to based on this new medicine, or you want to wait, or you want to reject it, and evidence needed next, whether you want to wait for another or better RCT or for guideline recommendations based on large societies like American Thoracic Society, European Respiratory Society, etc. So this is the simplest checklist that you need to keep in mind while critically appraising a research paper. So these were the references I had taken from. Then coming to this thesis work discussions. So this will be usually part of your critical appraisal, or there may be a separate station where they may discuss this. So what you need to know about your thesis work and how to prepare to answer anything related to your thesis. So before the exam, please go through your thesis once, because it would have been around 3 to 4 months since you have touched your thesis book. So first thing is memorize your topic name first, because when you tell something out of your topic and the examiner looks through that and he finds some disparities there, he will get an idea that there is some problem in the way whether you have done it or not, or you have given it outside for like many of the candidates who have done the thesis, they usually give it outside for this statistical analysis and all. So the examiner may have a suspicion on that. So that is number one. Number two is what you importantly need to know is whatever statistical methods you have used in your thesis study, read about those statistical definitions and the formulas related to that. Because if a well-versed examiner who is well-versed in statistics, in research on a regular basis, goes through your thesis, he is highly likely to ask questions in relation to that. Then you also need to know about the results of your study and whether you are using it in your practice in your ICUs. So that is one thing they will ask. So, for example, my study was based on a scoring system to predict for intradialytic hypotension in patients with AK admitted to the ICU. So once based on that scoring system, the examiner at the end asked whether this study had changed your practices. So I had told yes, because once I had done the scoring system and given it to the nephrologist, he had also given it to the dialysis unit. So they now routinely use it on a regular practice. Whether it is true or not, it is not important. But if the studies are very positive, please do comment this in the exam. It will be helpful. So this is also another thing that you need to keep in mind. So like I said, with regard to your thesis, please memorize the title of your topic. The methodology of your thesis needs to be kept in mind. The statistical tests that were used in your study needs to be kept in mind. The results need to be kept in mind, and how you are applying it currently, if it is a positive study, needs to also be kept in mind. So these are the important things that you need to know regarding your thesis work. When you are ask questions related to your thesis and you fumble, the examiner straight away knows that there are going to be a lot of mishaps. So then he will then start scratching you related to basic statistics questions, and then already many of the candidates will be stressed towards the end of the exam. So at that point of time, when they are asked about basic statistics, they will definitely fumble and you may lose marks there. So it is very important you know about this so that you don't get unnecessary questions and you don't get unnecessarily demoralized. So this is about the first talk. So critical appraisal and thesis discussion. So if anyone has queries, I'll be happy to answer them at the end. Or if there is any lack of time, then please put it in the WhatsApp group. So then I will answer them at the time when it is being asked. So this is now the second topic. This is usually asked in the second part of the Viva session. So it is a very, very high scoring area. Many people don't give importance to this. But if you do well in this station, it adds more marks to the final score. So with regard to quality indicators in ICU, the main areas I'll be discussing are the introduction, the objectives, parameters, and the final discussion in related to that. So quality indicator is a measure of structure, process, or outcome that can be used by local teams to improve care. So the main purpose of it is to help understand a system, compare it, and improve it. So quality indicators help us see problems that feel routine but are actually harmful. Example, one delayed discharge doesn't matter, but 10 delayed discharges every month, that is a system problem. Why residents should care? One is for your Viva and theory exams. For ICU audits, you will be forced to present in the future. For litigation and documentation. For ICU accreditation inspections like NABH or JCA. And when you become a future ICU in charge, quality indicator assessment, auditing all becomes a crucial part of your workload. So when something goes wrong in the ICU, we usually ask who made the mistake. Quality indicators force us to ask why the system allowed it to happen. So this quality measurement shifts the blame from the people to the process. So that is what you need to know about why quality indicators are important. So coming to the objectives, to select the very common parameters, mainly focusing on outcomes, that is morbidity and mortality, process, infection, human resources, and safety. So good ICUs fail in fewer dimensions, whereas average ICUs fail in more dimensions. It is as simple as that. So coming to the parameters, you have mortality parameter, morbidity parameter, operational or process, error and safety, infection control, and human resources. So under that, you have all these parameters that you need to look into. That is standardized mortality rate, iatrogenic pneumothorax or decubitus ulcers, length of ICU stay or ICU readmission rates, patient fall rate, medication error rate, needle stick injury rate, reintubation rates, VAP, CRBSA, CAR-T rate, resistance rates, and overall employee satisfaction rates. And in some ICUs, they have customer satisfaction rates also. So coming to SMR or risk adjusted mortality rate. So the rationale for doing this is raw mortality is not a good indicator of quality as it does not take into account the difference in cases or the severity of illness. So use of SMR calculated from appropriately calibrated severity of illness scores like Apache 2 enable comparable auditing controlling for the severity of illnesses by predictive models. So the population that is studied is all patients admitted to the intensive care unit. And the formula is the observed rate. That is the actual death rate in the ICU divided by the risk adjusted expected rate based on the Apache 2 score or the MPM score. Now this risk adjusted expected rate, how does it come? I will give the best example with an Apache score. Usually with Apache score, you calculate it based on certain parameters. When you take the total of it, it will give some number. So that number will have a percentage of mortality. Example, for an Apache score of 25, usually the predicted mortality is around 52.5%. So that 52.5% will be the one which will be coming here. So based on this formula, you will have to interpret it. If it is equal to 100, then the ICU mortality rate is equal to the expected rate. If it is more than 100, the ICU mortality rate is more than the expected rate. Whereas if it is less than 100, then the ICU mortality rate is less than the expected rate. So example, a tertiary ICU receives patients with septic shock, trauma, and referrals no one else accepts. The mortality rate looks high. If you look at the raw mortality, it is very high and it will show very poor on the ICU. But that will cause the administrators to panic. But when you look at the SMR, it is consistently below 1. What that means is high mortality with a low SMR means the ICU is saving patients, others can't. So that is what the significance of this is. So without SMR, ICUs learn to avoid sick patients instead of saving them. So this is an important message that you need to keep in mind. Next, coming to hydrogenic pneumothorax. So the rationale is procedure-related pneumothorax. Yes.
Sir, SMR, can you please explain it once more? Like
Sure.
in an ICU of 14 patients,
Okay.
how will we calculate, like every patient we have to calculate the Apache score and mortality, or?
Yes, for this, first you need to calculate, for every patient, you need to calculate the Apache 2 score.
Okay, sir.
All right. So when you calculate the Apache 2 score, you will get a number.
Okay, sir.
That number will have a predicted mortality. All right.
So for each patient, we will be calculating Apache
Yes.
score and the mortality rate. And
Yes.
we have to
That
add everything.
yes, you need to calculate all, and then you have to take the average of that. That is
Okay,
the
sir. Okay.
risk-adjusted expected rate.
Okay. Okay.
All
Okay.
right.
Thanks.
So that needs to be the denominator, and in the numerator, you need to take the total number of deaths that are there in the ICU.
Okay, sir. Okay.
So based on that, you will get the formula, and that needs to be interpreted accordingly.
Okay, got it, sir. Thank you.
Thank you. So coming to hydrogenic pneumothorax rate, the rationale is procedure-related pneumothorax is associated with increased morbidity and mortality. So for the population, it includes all patients admitted to the ICU. So the formula is pretty straightforward. The number of cases of hydrogenic pneumothorax divided by the number of ICU cases in a month divided by 1000. So the general benchmark is 0.83 divided by the 1000, that is by 1000 cases. So these benchmarks are all taken from ISCCM. So for example, why this is important? During a night shift, you have an hypertensive patient, a central line is done without ultrasound, pneumothorax occurs, and a chest tube is inserted. Now, what goes wrong is there was no ultrasound culture here, there was no senior supervision, and the complication was not logged. So the consequence because of this is there is going to be longer ventilation, longer ICU stay, and higher infection risk. So the cost further increases, and because the logging is not done, the same mistake repeats next week also. So that is the problem with hydrogenic pneumothorax if it is not being taken seriously. So if a complication is not counted, it will happen again. So this is why I was saying when a mistake happens, it is not because of the person alone. It's because of the problem in the process. If an ICU has a certain protocol like ultrasound guidance must be used. If it is going to be an anticipated difficult cannulation, a senior must be there on floor. Then the complication rate is likely to come down markedly. So this is the modifications that can help to avoid these problems. Then coming to decubitus or pressure ulcers. So the rationale is decubitus ulcers and pressure sores are synonymous. So prolonged uninterrupted pressure over bony prominences causes necrosis and ulcerations. The hip and buttocks alone contribute to 67% of the sores. So population, it includes all patients admitted to the intensive care unit, and the formula goes by the number of cases with pressure ulcers, that is new onset de novo, divided by the number of ICU cases in a month divided by 1000. So here the benchmark is 22.7 per 1000 cases or 3 to 11% of the ICU cases. So the example what we routinely see is a deeply sedated patient on vasopressors, turning skipped during hypotension, and ultimately they develop a sacral ulcer on day 3. So sedation targets are not discussed and turning is treated as a formality. So that leads to secondary infection, prolonged ICU stay, plastic surgery consult, family dissatisfaction, and legal questions can arise later. So pressure ulcers don't kill immediately, they poison the ICU stay because of the complications that are going to occur because of that. Because the patient would have come already for another problem, Now, because of this, you will have to deal another issue unnecessarily. So coming to the length of ICU stay. So the main rationale for this is ICU beds are limited in any hospital. Thus, rationalized use for needing patient is necessary. The length of stay is used to assess the quality of care and resource utilization. So these are the two important terminologies. Assess quality of care and resource utilization. Total hours and days patients managed in ICU with midnight bed occupancy is taken as the variable under consideration. All right. So how do we go about this is, usually if you have a 14-bedded ICU and you see that the bed occupancy at 12 a.m. is 10 patients. So that 10 patients is then taken as the length of stay for that day alone. That is then calculated for the whole month. The problem with this is the data that is present is going to be skewed. That is, there is going to be variability. Some days there may be 6 patients, some days there may be 10 patients, some days there may be 12 patients. So usually for assessment of length of stay, they tell to go with the median value. So here the formula is the total occupied bed days, that is the inpatient bed days. Like I said, the midnight census that is there at 12 a.m., the number of patients that are there at that point of time is noted, and the denominator is the total number of ICU discharges or deaths in a given time frame. That is in months usually. In some ICUs they take it in years. So that is taken as the formula, and the general benchmark is for a general ICU it is 4.3 days, and for vascular ICU is taken as 2.3 days. So patient is stable by day 4 but is still in ICU on day 10. The main reason is tracheostomy decision is delayed and a step down bed is not planned. The problem is because the decisions are postponed, there is no daily discharge goal. So that leads to a consequence of ICU bed being blocked, new critically ill patients are waiting in the ER, and worse outcomes for the next patients, that is the patients who are waiting in the emergency. So long ICU stay harms patients you haven't even admitted yet. So then coming to ICU readmission rate, that is within 48 hours of ICU discharge. The rationale for this is a high early, that is less than 48 hours readmission rate suggests poor ICU discharge decision making. So it can be due to discharges occurring before the patient is ready for ward-based care, incorrect use of ward care, or deficient handover to staff taking over care and responsibilities of the patient. So the population, it includes all patients admitted to the intensive care unit, and the formula goes by the number of readmitted patients divided by the total number of patients managed in the ICU. So the interpretation benchmark is 5 to 6%. So example, patient discharged at night to free a bed, minimal oxygen, borderline vitals, but returns within 12 hours with respiratory failure. So what goes wrong is the discharge is rushed, the handover is incomplete, and the ward is not ready. The consequence is there is a higher mortality risk on readmission. The family loses trust, and the ICU statistics worsen. So early readmission is not bad luck; it's basically planning failure. Then patient fall rate. So the rationale for this is an untoward event which results in a patient coming to rest unintentionally on the ground or another lower surface. Can be anticipated or unanticipated accidental event which is associated with increased morbidity, prolonged stay, and customer dissatisfaction. So it includes all the patients, and the formula goes by the number of falls by the number of bed days divided by 1000. So the interpretation is without injury, usually the benchmark is 2 to 2.6 per 1000 patient days. With injury, it is 0.22 to 0.7 per 1000 patient days. So a lightly sedated patient tries to mobilize. The nurse is busy over another ventilated patient. Unfortunately, the patient falls. So here what you can see is wrong is the sedation plan was not matched to the staffing and the risk was underestimated. So the problems that can occur is head injury can be there or any other bony fractures can occur. CT scan requirement may be there. It can lead to legal documentation and the family morale drops. So falls are rare, which is why each one is unacceptable. So then coming to medication error. So the rationale is it can be due to wrong prescription, wrong dose, or a communication gap, that is written or verbal. So it occurs at a mean rate of 19% of the hospitalized patients. At least 2% of this causes significant patient harm. So it again includes all patients admitted to the ICU. So the formula is number of errors by the number of bed days. So the number of bed days, like I told, is by the formula which I told earlier for the length of stay. So the number of patients who are admitted to the ICU are taken at the midnight census. So at the end of the month, the sum of those beds are taken and calculated for that number of days. Like if it is for 30 days and for each of the days, that is at the 12 a.m. midnight census, it was around 10 or 6 or 7. At the end of 30 days, the summation of that will give you the number of bed days. So that is the denominator. So the interpretation here goes by the median and the benchmark is 105.9 per 1000 patient days. Example, noradrenaline concentration changed during shift change. The pump rate was not adjusted and the patient becomes hypotensive. So what goes wrong is because of poor handover, that is, this change was not done, that thing is not being conveyed to the next staff. They are not aware of it, and there is no double check. The person who takes the handover also doesn't look into that. There can be organ hypoperfusion, AKA, and longer ICU stay. So this does not necessarily apply to noradrenaline. It can be to any high risk medication. So most ICU drug errors happen at handover, not during rounds, because most of the staffs who are looking after the patients don't want to do anything like intentionally. So many of the errors occur because of communication gap or during handing over, especially like during the shift change between like 1 to 2 p.m. shift change or between 7 to 8 p.m. shift change. If there is a medication that needs to be given at that point of time, many times it can be missed. Or if the patient is on infusions, correctly before handing over, they might have reduced the noradrenaline rate. Then they might be giving handover and they may not be noticing the blood pressure. Suddenly the BP falls, and then when someone walks by and notices, that's when they come to know that this error has occurred. So these are the problems that can occur because of medication errors. Then coming to needle stick injury. So it is a penetrating stab wound from needle or other sharp objects that may or may not be associated with exposure to blood or other body fluids. It is associated with transmission of bloodborne pathogens. It is preventable injury, hence adequate training to healthcare providers is a must. So it includes all healthcare workers, and the formula goes by the number of needle stick injuries reported in a month divided by the total number of staffs in the ICU divided by 10,000 venipunctures. So the benchmark is 0.94 per 10,000 venipunctures. So the example is your patient has undergone an emergency intubation at night. The resident recaps the needle out of habit, gets pricked. Now, what went wrong is, as it is when you work at night, you get fatigued. So your mind doesn't work properly. So it leads to an unsafe reflex action. The consequence is you will have to go for a HIV or HBV testing. There will be months of anxiety and the staff morale will get hit. So needle stick injuries measure fatigue actually more than the skill, because no, if you see the patients, like the staffs and doctors who come in the morning, they will be very cautious about these steps, about as per the need, disposal of sharps. They don't tell to recap it. They ask you to dispose it into the bin directly. So during the night, when our minds don't work well, this kind of errors are likely to happen. So this is mainly likely due to fatigue. So it needs to be kept in mind. Then coming to reintubation rates. So the rationale is reintubation within 48 hours of extubation. Accidental extubation and subsequent reintubation can lead to prolonged stay, longer ventilation, and higher nosocomial pneumonia rates. So it includes all patients admitted to the ICU. The formula goes by the number of patients reintubated by the number of patients extubated into 100, and the general benchmark is around 12%. So the example is a patient is extubated in the evening, he looks comfortable. By early morning, breathing worsens, patient is reintubated. So what went wrong is extubation was done too early, the fatigue was not recognized, no NAV or HFNC was planned, and monitoring is usually reduced at night. So the consequence is emergency reintubation, aspiration risk, more sedation days, higher infection risk, longer ICU stay, and higher chance of death. So reintubation means the disease didn't fail, our judgment did. All right, that is the important point you need to keep in mind. Then coming to VAP rates. So the rationale is VAP increases morbidity and mortality plus associated with increased length of stay and increased cost. So it includes all patients admitted to the ICU, and the formula goes by the number of patients with VAP by the number of ventilator days. So how do you calculate ventilator days? This is very commonly asked in the exam. Please know about it. It is the number of days a patient is mechanically ventilated with an endotracheal tube or a tracheostomy tube. So in the exam, if they ask, how do you practically calculate it? Like I said, for the length of stay, the same timing of assessment follows. While going with a midnight census, they usually take into consideration all the patients who are intubated or on the tracheostomy tube. So that census is taken into account. So if you have a 10-bedded ICU and you have 4 patients who are intubated, then the ventilator day for number of patients are 4 patients on ventilator. So the ventilator days for that one day is 4. So for 30 days, it is calculated and then it is averaged. So that gives you the number of ventilator days. So the interpretation is for trauma ICU, it is 9.3 per 1000 ventilator days. Then medical ICU is 2.5 per 1000 ventilator days. Neuro ICU is 7.1 per 1000 ventilator days. And neurosurgical ICU, it is 6.5 per 1000 ventilator days. Coming to bloodstream infections due to central line rate, that is CRBSA rates. So the use of CVCs is indispensable to the treatment of critically ill patients. So this all of us know. Infections is one of the most common complications of intravascular catheters, and it is associated with increased morbidity and increased ICU length of stay by at least 5 to 8 days. So it includes all the patients admitted to the ICU, and the formula goes by the patient's number of patients diagnosed with a central line associated bloodstream infection divided by the number of central line days in a month. Again, this calculation is similar to the ventilator days. So here you need to take the number of patients at 12 a.m., the midnight census when it is being taken. At that time, they usually take the number of patients with the central line in situ. So in a 10-bedded ICU, 2 patients or 3 patients may be having a central line on one day. Then the subsequent day, they may have another 2 patients who may have another central line. So then it adds up. Then when the requirement is not there, it may get removed, or a new patient may get admitted and they may need a central line. So it may vary each day. So at the end of the month, the number of patients who had a central line for each day is calculated, and then it is summed and then averaged. So that will give you the number of central line days in a month. So the benchmarks that you need to know is in a medical ICU, it is 2 to 4 per 1000 central line days. Trauma ICU, it is 4 per 1000 central line days. Neuro ICU is 1.2 and coronary ICU is 2.1. Then comes the CAR-T rates. So it's similar to CRBSA and ventilator days. It is associated with increased morbidity, length of stay, and cost. Includes all the patients admitted to the ICU. So the formula is number of patients diagnosed with CAR-T divided by the number of CAR-T days. So like I said, for ventilator days and catheter days, even for a urinary catheter days is calculated in a similar fashion. So urinary catheter or SPC, both are taken into consideration. Some may ask whether condom cath comes under this. No, condom catheters do not come under this subset of calculations. So the benchmark is medical ICU, it is 4.1, burns ICU, it is 7.7, neurosurgical ICU, it is 6.8, and surgical ICU, it is 4.1. From exam perspective, it is very difficult to memorize the numbers. At least remember 1 to 2 of these, medical ICU or a surgical ICU or a neurosurgical ICU, like that. Or if you are not very sure in the exam, just comment between 4 to 7. Some number may fit. All right. Because in the heat of the moment, it is very improbable that you will remember all the numbers. Just remember between 4 to 7 in most of the instances. But when they ask benchmark, please don't give a reference range. Please mention a single number. So infections increase with tubes and time. So more number of tubes, more the risk, and more the duration of the tubes, more the risk. So another parameter you need to know is something called the resistance index. So it is used to assess the epidemiological trends of organisms in the ICU. So antimicrobial resistance associated with greater morbidity, mortality, financial burden, and length of stay. So it includes all the patients admitted to the ICU, and the formula goes by the number of resistant isolates by the number of isolates tested into 100. The important thing you need to keep in mind is here at least 30 isolates are needed for accuracy and precision. So the interpretation varies from institute to institute. So it provides the foundation for selection of antibiotics specific for a set of infections. So that is why you need to know about this resistance index. Then comes to the overall employee satisfaction. So the main rationale for doing this testing is for assessing the satisfaction level of staff working in ICU. Satisfied workforce gives better output and the retention rate will be high if it is a good ICU team. So it includes all the staffs working in the ICU. The formula goes based on a questionnaire from 1 to 5, where 1 is the lowest satisfaction and 5 is the highest satisfaction. So the interpretation, the benchmark is 4. So an example is you have an overworked ICU. There are no major mistakes, but the nurses stop speaking up because of the work stress, and the residents stop escalating because of the burnout occurring. So what goes wrong is burnout is getting ignored. So that leads to early warning signs being missed in the patients, sudden unexpected crashes, and poor team culture. Because if there is not a good team coordination or there is no chemistry between the staffs and the doctors, they are not going to come and discuss certain things with you. Because sometimes when the doctors are being very rude to the staffs, their morale is low. So when they are able to pick up things, they'll have a double thought whether they have to come and tell you or not. So that itself will create problems. So that is why overall satisfaction is very important, and for that a good ICU team chemistry is very important. So a tired ICU doesn't fail loudly, it actually fails quietly. So then comes to the last part, that is the customer satisfaction rate. This usually is very unlikely to be asked in the exam, but just for completion purpose, I've kept this. The rationale for this is patient satisfaction is perceived parameter by the patient. It reflects the performance of the hospital as reflected by the patients and their relatives. So all patients admitted to the ICU and is able to give capable of giving a feedback are taken into consideration. Or if they are not able to do so, then the relatives take the effort of it. It is again a questionnaire based, but here the point scoring is from 1 to 10, where 10 is the best service possible. So the benchmarks is satisfaction to physician communication has to be 80%. Nurse communication is 74%, cleanliness is 70%, noise is 50%. Then pain management 68 and recommend hospital others is 68. In this, importantly, you need to keep in mind is about communication, physician, nurse, and cleanliness. It goes as 80, 75, and 70. So those things you need to keep in mind. So every quality indicator represents a patient who paid the price. So quality improvement doesn't stop mistakes, it stops the same mistake from happening again. Like I said for hydrogenic pneumothorax, if the process is proper, you have a proper ultrasound culture, you have a proper culture where if you have a difficulty, you intimate the senior on floor, then the likelihood of it occurring becomes very less. So good ICUs treat patients, but great ICUs fix the system. So this is about quality indicators. So now we'll go into the interactive sessions. So we'll just take a 2-minute break and then we'll go ahead.
Great, sir.
Sir, you are not audible, sir.
So we'll come to the third talk. So this one will be more of an interactive session. So I'll be talking about ECGs first. Then I'll be discussing about ACLS and BLS. So under
Sir,
ACLS and yes.
sir, can I ask one question that previous?
No, sorry, please. Please keep the request towards the end, or please put it in the chat box. I'll be happy to answer it because we have a few more
Okay,
topics
I
to
will put it
discuss.
in the chat box, sir.
I will discuss it later on. I kindly request the candidates not to interrupt the flow because it will affect the ones who are listening. So coming to ECGs, BLS and ACLS. ECGs, I will be keeping it more like an interactive session where I'll be showing the ECGs and you will have to identify it. Then we'll have a small discussion about it and go ahead. For BLS and ACLS, we will go with the example for a bradyarrhythmia and a tachyarrhythmia, and towards the end, we'll have a small discussion in relation to the 2025 updates. So this will be the main core areas that we will be discussing. So just a second. So coming to the approach for ECG, so this is one thing you will need to keep in mind. When you go about an ECG, you need to know the rate, the rhythm, the axis, P wave, the PR interval, the QRS complex, the ST segment, the QT interval, and the U wave. So the normal reference ranges are the ones I've put up. So for PR interval, it is 0.12 to 0.2 seconds. For QRS, it is 0.08 to 0.12. ST segment elevation, for ST segment, you need to assess for J point elevation. QT interval, you need to assess based on the Bassett score, that is the corrected QTC, that is less than 0.44 seconds normally. And for U wave, it represents the repolarization of the papillary muscles and the Purkinje fibers. So this is one thing they are likely to ask in the exams. So coming to the first ECG, so when you know the answers, please put it up in the chat box. So I'll give around 30 seconds for each one, and then we'll go on to the discussion. Excellent. So most of you have given a good answer. So the answer here is atrial fibrillation. So it's irregularly irregular. There were no P waves, absence of isoelectric baseline, variable ventricular rate. The QRS complex is usually less than 120. Fibrillatory waves may be present and can be either fine or coarse. And the fibrillatory waves may mimic P waves, leading to misdiagnosis. So that is one thing that you need to keep in mind. So coming to the next one. So only one person has answered. So it's a hard block, but it's not a complete hard block. You can see there is something which is being regularly missed. Exactly. So it is a second degree type Mobitz type 2 block. So you have three types. You have first degree, second degree type 1, type 2, and third degree. So not going to in the depth of it. So for most of you are aware of the types of heart blocks. Usually second degree heart block, Mobitz type 2, and third degree block are the ones which will be commonly kept in the exams. Please don't make mistakes in those. Excellent. So uh, three answers were right. One answer isn't. It's not an SVT. It is a flutter. All right. So it's a narrow complex tachycardia. Regular atrial activity at 300 beats per minute. Loss of isoelectric baseline is a sawtooth appearance. So this is the important thing that you need to look into. So diagnosis. Excellent. So it's a ventricular fibrillation. Excellent, excellent. What about this? Superb. Excellent. So most of you know about it. So it's any other answers? Anyone else wants to add on? Okay. So it's Torsade de pointers. No, it's not monomorphic VD, it's Torsade de pointers. Okay. So what does this ECG show? Anyone? The correct answer is there, but sine wave, okay. What is the defect? Okay, fine. So we'll go ahead. We'll go ahead. It's hyperkalemia. So the important thing in the exam, you need to know about this potassium levels and the associated ECG changes that can occur. So that is very, very important. That needs to be memorized before the exams. So for 5.5 to 6.5, you will have peak T waves. 6.5 to 7, you will have P wave widening or flattening. Then you PR prolongation and P waves eventually disappear. Then 7 to 9, you will have bradyarrhythmias. Then more than 9, you will develop this sine wave appearance. All right. So I think few of you got it right. It's a good thing. So we have something called the push and the pull effect. So with hypokalemia, there will be more of a push. It is you'll have T wave inversions, ST depressions, and the prominent U wave. Whereas with hyperkalemia, you will have peak T waves, P wave flattening, PR prolongation, and wide QRS. All right, so that is what you need to keep in mind. Diagnosis. This is a tricky ECG. Please look into it properly and answer. This is more like a quiz question. Excellent. It's Osborne. So in this case, the presence of this Osborne, what does it signify? Three people have answered. I think Sriram, Jogender, and Bhavna. So why is Osborne wave present? Excellent, excellent. It's hypercalcemia is what I would say, because hypothermia, if it is present, you need another two important things. Shivering artifacts have to be there, and the next thing is you need bradycardia to be there. So this is like sinus rhythm and with presence of Osborne. So the high first priority would go for hypercalcemia. So Osborne waves are seen in severe hypercalcemia. So the main ECG abnormality is a short and QT interval, whereas in hypocalcemia it will be a prolonged QT interval. So in severe hypercalcemia, Osborne J waves may be seen. And ventricular irritability and VF arrest have been reported in extreme hypercalcemia, but very rare. Diagnosis. Okay, I think. Okay, super. So everyone know about this. These are like the no mistake to be done ECGs. All right. So this is a typical hypokalemia related ECG. So you see T wave inversions, then U waves also being present. So the other features that can be there are increased P wave amplitude, prolongation of PR, widespread ST depression and T wave flattening or inversion, and prominent U waves. So what is this phenomenon? Anyone? Excellent. Yeah, it is going into it is going into torsades, but this thing over here is something called the R on T phenomenon. All right. So it is usually seen in patients who have QT prolongation and there is an arrhythmia occurring, sorry, an ectopic occurring, and that triggers a torsade pointers. Excellent. Okay. What abnormality can you see and what is the diagnosis? Superb. So what does that indicate? Excellent, excellent. So it is a Wolf Parkinson White syndrome. All right. So okay, what does this CCG signify? Exactly. So like I said, you will have in a hypothermia, you will have bradycardia. Along with that, you will have the shivering artifact and Osborn waves. So that is one way you can differentiate between hypercalcemia and hypothermia. Diagnosis? Okay. Anyone else? Okay, fine. So it is a massive bilateral pulmonary embolism. So some of you mentioned right bundle branch block. That's okay. Some of you told S1, Q3, T3. That is also okay. So one or two of them told pulmonary embolism. That's good. So massive, but the important thing to note is S1, Q3, T3. The sense specificity is good, but the sensitivity is very, very low. So that is one thing you need to keep in mind. But the most common arrhythmia that you see in a P is a sinus tachycardia. So that is one thing they can ask you in a short case or a long case itself. So be prepared for that. So what does this signify? Excellent. All of you seem prepared for the exam already. Exactly. It is an electrical alternance. So you can see low QRS voltage tachycardia and variations in your ECG voltages. Diagnosis. Excellent. So one person has told it correctly. The first person had mentioned it as posterior STEMI. If you look at AVR, you can see something significant. All right. So it is supposed to be a dextrocardia. All right. So when you see a normal sinus rhythm, but the lead, you see the inversions and the are kind of abnormal, then always look at AVR. That will give you a perspective. So we have a 24-year-old male, a known case of type 1 diabetes, Was broad with history of sudden onset giddiness and drowsiness while playing basketball with colleagues. What does the ECG show? Superb. Everyone have told it correctly. But my question is, how do you come to that diagnosis of Brugada? Why do you say it's Brugada? I think 7 or 8 of you have told Brugada. Why? Fine, we'll go ahead. So you have type 1 and a type 2. So the one which I showed previously was a type 1. So here you can see ST elevations with a downsloping ST segment and a inverted T wave. So usually it is seen in V1 and V2 predominantly. ST elevation, downsloping ST segment and a T wave inversion. All right. So this is supposed to be characteristic for a Brugada syndrome. Diagnosis. Anyone else? Excellent. It's supposed to be an ECG of an acute pericarditis. All right. So we have widespread ST elevation with PR depression through most of the limb leads. All right. And reciprocal ST depression and PR elevation in lead AVR. So sinus tachycardia is also commonly present because of pain and pericardial effusion. The one important thing you need to know is something called the Spoddick sign. Can anyone tell me what's Spoddick sign? Okay, no problem. So downsloping TP segment that is seen as an early ECG manifestation in about 30% of the patients with pericarditis. So it is best visualized in leads 2 and the lateral precordial leads. All right. So it is a potentially useful distinguishing ECG feature between acute pericarditis and ACS. All right. So you need to know about something called the Spoddick sign when you interpret a pericarditis ECG. Diagnosis. Okay, so two people have answered. It is reverse tick sign, yes, accepted. But it doesn't come as part of digoxin toxicity. It comes as part of digoxin effect. Okay, so it is downsloping ST depression with a characteristic reverse tick or Salvador Dali saggy appearance. So there will be flattened, inverted or biphasic T waves associated and a shortened QT interval. So, patient with recent ACS with intermittent episodes of angina. What is your diagnosis based on the ECG? Excellent. So two people have told it. So this is another ECG with a similar kind of variant of it. So the first one was a Wellens type A. Here you can see. And the second one is a Wellens type B. All right. So Wellens syndrome is a clinical syndrome characterized by biphasic or deeply inverted T waves in V2 to V3 plus a history of recent chest pain now resolved. It is highly specific for critical stenosis of the LAD. So the pattern usually presents in a pain-free state. It may be obscured during episodes of ischemic chest pain when there is pseudo-normalization of the T waves in V2 to V3. So Wellen syndrome is a key example of why all patients with chest pain must have serial ECGs. All right. Anyone? Okay. I think that's a good answer. But why do you need that? Exactly. Superb. So that's the basic answer. So it's basically a posterior wall MI. It's characterized by ST depression in V2 to V3, tall broad R waves in V2 to V3, dominant R wave in V2. All right. And the terminal portions of T waves in V2 to V3 are upright. So in this scenario, you need to take the posterior leads, that is V7, V8, and V9. All right. So when you get that ECG strip with the posterior leads, you will be able to elicit ST elevations. So I think two people got a good answer here. So the next diagnosis. Inferolateral, inferior anterior MI. Okay. Okay, fine. So that could be one. Ah, exactly. It it is supposed to be RVMI. All right. So patients with an inferior STEMI, RV infarction is suggested by ST elevation in V1, ST elevation in V1 and depression in V2. That is supposed to be highly specific for RV infarction. ST elevation in 3 more than 2. So this needs to be confirmed by right-sided lead placement. So that the most useful lead that they say is the V4R. So the same repeat ECG, sorry, repeat ECG of the same patient with the V4R electrode showed ST elevations. So that's supposed to be consistent with an RV infarction. So based on this ECG, here you can see there is lot of STT changes. Which artery is likely to be involved? Left main, no. You can see there is ST depressions in. Okay, so we'll go ahead. So here you can see the main reason why I put this is to know about the localization. All right. So one AVL V5 V6 is lateral, so can be suggestive of a left circumflex. So anterior leads predominantly correlate with an LAD, and the inferior go ahead with an RCA or a PDA. So when there is an inferolateral also being present, then there can be a possibility of a PDA, because there can be two origins which can be suggesting to that. All right. So this is something that you need to keep in mind. So most of you do know about it. Just before the exam, have a small revision. So I'll just be discussing about cardiac pacing, because in hemodynamic monitoring station, along with the other devices, they may keep a temporary pacer as one of the gadgets that can be asked. So I just thought I'll elaborate on that and a few pacemaker related ECGs. So coming to cardiac pacing, so temporary venous pacing involves electrical cardiac stimulation to treat symptomatic bradyarrhythmia until it resolves or until long-term therapy can be initiated. The purpose of temporary pacing is to re-establish normal hemodynamics that are acutely compromised due to a slow heart rate. So the pacing techniques that can be done are internally using transvenous endocardial leads, externally via transthoracic patches, or internally via atrioventricular epicardial leads placed at the time of surgery, or internally via esophageal electrode, which is primarily used for atrial pacing and recording. So the main indications for pacing are electrolyte disturbances like hyperkalemia or hypercalcemia, drug toxicities, post-procedural injury to the sinus node, AV node, or His bundle. That can be because of post-cardiac surgery, post-heart transplant, trans-aortic valve transplantation. Then infections like Lyme's disease, Chagas, or subacute IE, damaging the His-Purkinje fibers, acute MI, and permanent pacemaker revisions due to PPA infections or lead failures. Please memorize this, because if they are going to keep a pacemaker device in your exam, they are going to ask, the first question they are going to ask is the indications. The important thing related to pacing is it should be kept for the shortest time possible. Contraindications, absolute, there are no absolute contraindications, but relative prosthetic tricuspid valve is considered as a relative contraindication because of the risk of damage, and if the patient has received thrombolysis. So for the procedure, if they ask how it is done, the preferred vascular access is a right IJV or a right subclavian. Because why it is so? The curvature of the pacing lead, the ease of advancing the lead into the heart, and the underlying venous anatomy. So transvenous lead placement, the only ventricular lead is inserted. So once the central venous axis is secured and the sheath is introduced and in place, the transvenous lead is inserted and advanced based on markings indicating the distance from the tip. It can also be confirmed with echo and fluoroscopy. So continuous ECG monitoring is recommended in all patients, as VPCs or non-sustained VTs is seen when the lead is in contact with the RV. Then the lead is connected to a pulse generator. So regarding to the pacemaker programming, the mode that is kept is VOO. All right. So this ventricular pacing alone is there. The other two OO is the sensing and the rate modulation is not there. So the settings are heart rate is kept between 60 to 70 beats per minute. The pacing sensitivity, it is usually kept maximum. Then it can be set between 0.8 to 20 based on the uptake. So when you mention about pacemaker sensitivity, they can ask you the definition of it. So sensitivity is the minimum current at which the pacemaker is able to sense intrinsic rhythms. It is expressed in millivolt. So the lower the number, the more sensitive the pacemaker. Then you have pacing threshold. It has to be lesser than equal to 1 milliampere. So pacing threshold is the minimum pacing output required for the pacemaker capture. Meaning to say, the minimum pacing output at which an action potential is generated leading to a myocardial contraction. Then you have pacing output. that is about 2 to 3 times of the pacing threshold. So the pacing output is the current with which it produces a brief pulse. So we have three important parameters: sensitivity, threshold, and output. Sensitivity initially maximum, then you reduce it to the lowest possible, but it is kept anywhere between 0.8 to 20. Then pacing threshold lesser than equal to 1 milliampere, and pacing output has to be 2 to 3 times of the pacing threshold. So complications. So it is important to monitor for these while transvenous pacing is in situ. The complications that can be there are lead dislodgement and disconnection, bleeding, myocardial perforation leading to a tamponade, pneumothorax, infections, catheter knotting, and air embolism. This is also a high probable question that can be asked. Please note it. So clinically, how you can assess for this is post-procedure, patient should be examined on a regular basis for pericardial friction, which may be indicative of cardiac perforation. Hypotension with muffled heart sounds and jugular venous distension is suggestive of a cardiac tamponade, or asymmetric or absent breath sounds suggestive of a pneumothorax. So with regard to the 2021 guidelines, pacing is indicated in symptomatic patients with bradycardia, tachycardia form of sinus node dysfunction to correct bradyarrhythmias, and enable pharmacological treatment unless ablation of tachyarrhythmia is preferred. So this is a 1B. Pacing is mainly indicated in patients with atrial arrhythmias and permanent or paroxysmal third degree or high degree AV blocks. So if they ask any guideline recommended, guideline recommendation, then you will have to mention about this. So coming to permanent pacemakers, most management decisions regarding permanent pacemakers are driven by the following factors. One is association of symptoms with bradyarrhythmias like dizziness, lightheadedness, syncope, and fatigue. And location of the conduction abnormalities. His infrahisian AV blocks are second degree Mobitz type 2 to 3 heart blocks. So in these cases, PPA is shown to improve outcomes, and there is an absence of a reversible cause. So these three are the important things you need to keep in mind when they put a PPA. So the class 1 indications are symptomatic bradycardia, symptomatic sinus bradycardia due to long-term drug therapy of a type or dose where there is no acceptable alternative, complete heart block with or without symptoms, and symptomatic second degree block. The contraindications are excessive risk of bleeding due to vascular access, ongoing bacteremia, intracardiac thrombus, and prosthetic tricuspid valve. So these are all the contraindications for a PPA. So the parts are, here you have a battery, that is a power source that generates the impulse. Then you have a circuit that controls the pacemaker operations, the leads, insulated wires that deliver electrical impulses from the pulse generator to the heart, and the electrodes, the conductor at the end of the leads that delivers the pulse to the heart. So these are the four important parts of the pacemaker. So the pacing nomenclature, you have something called the British Pacing and Electrophysiology Group. Based on that, they have 1, 2, 3, and 4. So you have the chamber paced, sense, the response, rate modulation, and multi-site pacing. So the important things you need to remember are these three, because these three apply to the temporary pacing mainly. So the first one is paced, the second is the sensed, and the third is the response to sensing. All right. So rate modulation, what it means is it uses a physiological sensor other than the sinus node to adjust pacing rate according to the physiological need of the patient. And multi-site pacing, it is rarely used, mainly for anti-tachycardia or resynchronization function. So this is just for exam perspective. If at all they keep a permanent pacemaker, you may need to know about this. Then there is something called overdrive pacing. So it creates a re-entrant pathway that bypasses the AV node. So it disrupts the re-entrant circuit and overrides the ectopic pacemaker, changing the pattern of depolarization and creating more uniform repolarization. So in refractory VT, overdrive pacing increases the rate of depolarization decreasing the ventricular refractory period, reducing the susceptibility to the R1T phenomenon. In AV junction tachycardia, atrial flutter, and SVT with rapid ventricular response that fails to report can be controlled with overdrive pacing. So usually an external electrical impulse at a rate of 10 to 20 beats per minute greater than the native rate needs to be kept. So that is the important thing regarding to overdrive pacing. So regard to ECGs again, so if at all they keep pacemaker related ECGs, one is they may keep a normal atrial and ventricular pacing spikes. So here you can see normal atrial and ventricular pacing spikes that are present, indicating a dual chamber pacing. So here you can see ventricular paced rhythms. So after every ventricular pacing, there is a ventricular contraction that occurs. So pacing abnormalities, the first one you need to keep in mind is failure to capture or pacing failure. This is supposed to be the commonest. So the ventricular spikes follow P wave, but there is no pacing thereafter. So here you can see there is pacing, but no contractions. So when they keep this ECG, the next question they ask is what are the etiologies? So one, it can be because of lead dislodgement or malposition. So management is reposition. Inflammation at the electrode surface, again, you will need to reposition and increase the output of the pulse generator. So that is why I told between 0.8 to 20 is what you can adjust. So patients who have the pacemaker for a long period of time, that is more than 1 week, there is a risk of inflammation at the electrode. So in that kind of a scenario, then you will have to increase the output of the pulse generator. Then battery depletion. So for that, you will need to change the battery. Pulse generator failure, again, you will need to replace the generator. Lead maturation, you will have to evaluate the change in sensing, and magnet application, if it is there, you will have to remove it. So these are the etiologies associated with failure to pace. Then you have rapid ventricular pacing. So rapid ventricular pacing rhythm with no evidence of preceding atrial activity except for the first complex can be because of two etiologies: pacemaker mediated tachycardia and sensor mediated tachycardia. So for pacemaker mediated tachycardia management, temporary management is apply magnet to the pacemaker pocket and change to asynchronous mode. And definitive management is reprogramming of the pacemaker. Then in the older generation of pacemakers, there was a complication which used to frequently occur, that is the runaway pacemaker. So that is paroxysms of rapid pacing spikes of about 2000 beats per minute with decreasing amplitude and rate. So this fails to excite the ventricles due to low amplitude spikes. So for runaway pacemaker management, you need to disinhibit the pacemaker with magnet and urgent implant a temporary pacing device if the patient is pacemaker dependent. And the definitive management will be reprogramming of the pulse generator. So the complications are almost similar to those of the transvenous pacing, except that you also have risk of catheter knotting, air embolism, then pacemaker, runaway pacemaker, and pacemaker mediated tachycardia. So these are the other things also you need to keep in mind. So what abnormality can be identified here? So if you know the answer, please put it in the chat box. Okay. Anything else? Okay, fine. We'll go ahead. So it's a left anterior fascicular block. So left axis deviation is there. All right. So, okay, someone told failure to sense. No, we came out of that pacemaker topic. Now, this is about the general ECG discussion. So, few things that you need to look into is QR complex in leads 1 and AVL, and RS complexes in 2, 3, and AVF. So that will indicate a left anterior fascicular block. So this is just in the exam, there is these may be kept. So just giving an orientation to this. Patient was brought in an unconscious state, intubated in ER. ECG showed the following. So the abnormality seen and diagnosis. Yes, it is a drug toxicity. It would be nice to elaborate on the drug toxicity. Okay, TCA poison, excellent. But based on what findings did you say it is a TCA? Okay, sinus taxi, excellent. White QRS, excellent. Okay, fine. So I think this is there, but there are a few other things also you need to see. All right, it is a TCA overdose. So here you can see there is an interconduction delay. The QRS was more than 100. So you told that correctly. Then there is sinus tachy because of anticholinergic effect. That is a muscarinic M1 receptor blockade and terminal R wave more than 3 mm in AVR or RS ratio more than 0.7 in AVR. This is one other thing that you need to keep in mind. All right. So it is a TCA overdose. So having discussed about all of this, this is the list of ECGs that will be kept in the exam. So if you have the time, please do prepare a list for yourself so that you can revise it. And also, when you mention in the exam, please don't go straight ahead and answer the diagnosis. Mention in a systematic format. If the examiner tells you you don't need to tell all that, just tell me the diagnosis, then you tell the diagnosis alone. If you jump directly into the diagnosis, it may backfire for you. So be very cautious when you answer the ECGs. Always go in a stepwise format. So these are the list of ECGs that will be kept in the exam. Please do make a note of it. In acute pericarditis, please don't forget about sporadic sign. So coming to ACLS and BLS, so I'm just keeping a small scenario. So usually, most of the time, the scenario which will be kept is a cardiac arrest scenario, and they will have a mannequin over there and they will ask you to demonstrate it. So that will be the most common thing which will be there. These are two scenarios which are kept are probable discussions that can be there based on images that are kept, and they can give you a scenario and ask you how to proceed from there on. So a 65-year-old female patient, a known case of COPD, hypertension and diabetes was admitted in your ICU with history of cough and breathlessness. She was diagnosed as a case of community-acquired pneumonia and initiated on antimicrobials and non-invasive ventilation. During the course of stay, she developed worsening breathlessness attributed to cardiogenic pulmonary edema due to sepsis-associated cardiomyopathy, for which she was initiated on diuretics. During a night shift, while attending another patient, the nurse calls you saying that the patient is tachycardic with an abnormal rhythm. You see the patient and see the following ECG on a multipara monitor. So, how will you proceed? So, if at all one volunteer can tell me how to proceed, then we can go on with the further discussion. Anyone can volunteer. Okay, I think lot of candidates are kind of shy, I suppose. So how will you proceed is you go with the AHA guidelines. First is you assess the appropriateness of the clinical condition. Heart rate is more than 150 beats per minute. You identify and treat the underlying cause. All right. So your first thing is you maintain a patent airway, assess breathing as necessary, oxygen if hypoxic, cardiac monitor to identify rhythm, monitor BP, SpO2, an IV axis, and 12 ECG. In this, the important things I want to emphasize is all these are AHA based. So in the exam, when they ask you, most of the patients who are there in the ICU will already have an IV axis. So you can just tell that already an IV axis has been placed. And if the patient is on O2 therapy, or like in the form of a non-invasive ventilation, then you can just say you will adjust the settings as needed. And based on the mentation of the patient, you will decide about the airway. So this is how you will have to modify your answers. It doesn't have to exclusively be the same thing as per the AHA. So persistent tachyarrhythmia causing hypotension, altered mental status, chest pain, and signs of shock with acute heart failure. If any of these are present, then you need to go with synchronized cardioversion. Consider sedation. Airway equipments need to be kept at the bedside as standby. And if regular narrow complex, consider adenosine. So if it is refractory, you will need to treat the underlying cause, need to increase the energy level for the next cardioversion, addition of antiarrhythmic drugs, and expert consultation. So for synchronized cardioversion dosing, for a regular narrow, it is 50 to 100 joules. For irregular narrow, it is 120 to 200. Wide regular, it is 100. And wide irregular, it is defib dose, not synchronized. So if it is the features of hypotension, altered state, mental state is just pain, shock, or heart failure is not there, then you need to assess if the QRS is wide. If the QRS is not wide, it is narrow complex, you go with vagal maneuvers, adenosine, beta blockers, or CCBs, and expert consultation. If it is so, you consider only adenosine if it is regular and monomorphic, and the antiarrhythmic infusions like amiodarone and procainamide. With either of them, if it is refractory, then you will have to treat the underlying cause. Then you will have to add a second antiarrhythmic agent and consider expert consultation. So this is the tachycardia algorithm which is there. In the previous 2020, in these medications, sotalol was there. Sotalol has been removed. So that is one thing you need to keep in mind. So these are the other things that are there. Please memorize it before the exams. For bradycardia, this is a similar situation, but sorry, this is another case scenario with the bradyarrhythmia. So again, if the heart rate is less than 50, you identify and treat the underlying cause. The same assessment goes: airway, breathing, circulation, cardiac monitor, IV axis, and 12-lead monitoring. The important thing is you need to look for possible hypoxia, MI, hyperkalemia, and toxicology causes like beta blocker, CCB, digoxin, or OP compounds. If persistent bradycardia is there causing, which is symptomatic, then if it is not there, you just monitor and observe. If it is there, IV atropine is your first line drug. First dose is 1 milligram bolus. Repeat 3 to 5 minutes, maximum 3 milligrams. If atropine is ineffective, you can go with transcutaneous pacing and or dopamine infusion, 5 to 20 mics per kg per minute, and or an epinephrine infusion of 2 to 10 mics per minute. The important thing here is dopamine is kg based, weight based. Epinephrine is not weight based. So that is an important thing you need to keep in mind. The examiners will ask. And consider expert consultation and transvenous pacing. So oral therapies, which is not AHA recommended, but that can be asked in the exam, is thiophyllene, 5 to 10 milligrams per kg per day in divided doses can be given. So this is about the bradycardia protocol. So here, most of the things you will answer, but with regard to the possible causes, please read about this in depth because they will ask you about this particularly if they go into bradycardia assessment. So here you have, I've just put these algorithms for based on the AHA 2025. I'm not going into the depth of it. This is just for your reference. Like before your practical exams, if you're looking through these videos, then you can just pause it and have a look into it. All right. So memorize this cardiac arrest algorithm every day. Read about it for at least 1 to 2 times, because in the exam, in already that full stress, you will not be able to remember everything at that and the heat of that moment. You are likely to make mistakes, so keep practicing it so that when you go there and perform it, you will not make any mistakes. Honestly, during my practicals, I made a big blunder with CPR, the cardiac arrest rhythm. Good thing is they are not as stringent as IDCCM exams, because in IDCCM, if you make a mistake in AHA, you will be failed. But in DRNB, that is not an issue. So they told it's okay. But then later on, they like asked another few set of questions, which I answered well. So I escaped. So with regard to cardiac arrest algorithms, do not make any mistakes. Be very like cautious about what you're doing and performing over there. These are few areas which they will ask in the exam. That is why I've put these. One is about the BLS termination of resuscitation rules and ALS termination of resuscitation rules. So for BLS termination, arrest not witnessed by emergency medical service personnel, no return of spontaneous circulation, no AED shock was delivered. So if all criteria are met, then consider termination of resuscitation. For an advanced life support, arrest not witnessed, no bystander CPR, no ROSC, no before transport, and no shock was delivered before transport. If all four are satisfied, then you consider termination of resuscitation. So this is just a table showing the changes between the 2020 and 2025. So with regard to the initial action, it is the same, but explicit CPR first, monitor early framing. Shock strategy, it is the same, but strong discouragement of stacked shocks and double sequential defibrillations on a routine basis. Epinephrine timing, clear sequencing. You in non-shockable rhythms, you need to give it as early as possible. In shockable, after the initial shock itself, you can give it, is what they say. Antiarrhythmics, it is the same drugs, no new agent has been added. Airway, do not delay CPR for airway. The emphasis for it has become stronger. Ventilation after airway, it is the same, but explicit warning against hyperventilation. For capnography, strongly emphasize for tube conformation and CPR quality. With regard to CPR quality feedback, explicit endorsement of real-time feedback devices is now being taken into consideration. The 5 H's and 5 T's checklist is still the same, but is now embedded into team leader prompts. And termination of resuscitation is now integrated into system of care thinking. So with regard to bradycardia with pulse, assessment is the same. The first drug is the same. If atropine fails, the same options, but earlier transcutaneous patient is encouraged in unstable patients. So the algorithm tone is now decision focused, like stable versus unstable. With regard to tachycardia with pulse, the stability check, if it is if instability is there, you immediately go with synchronous cardioversion. Then the QRS with, it is still the same. Adenosine, it is still the same, but explicitly diagnostic was and therapeutic. Irregular white complex, stronger wording, treat as VT unless proved otherwise. For polymorphic VT is still the same, and it now provides cleaner and faster branching compared to the previous algorithm. With regard to team dynamics, the team leader, the central role explicitly defined. Closed loop communication is evaluated now during megacode. Role clarity is mandatory expectation, and CPR metrics is now actively monitored, which was optional in the 2020 AHA guidelines. So the take-home message from the AHA 2025 is there are no revolutionary drugs or drug dose changes. The real shift is implementation science, that is timing discipline, CPR quality measurement, and leadership over algorithm memorization. So, question to all the candidates, what is etripamil? This is likely to be kept in the exam. It is now a new drug which has been FDA approved. Okay. CCB is fine. What is it used for? Okay, fine. We'll go ahead due to want of time. So, atripamil is a short-acting intranasal CCB. All right, used for patient-initiated termination of paroxysmal SVT due to AV nodal dependent re-entry. So, it's a non-dihydropyridine L-type calcium channel blocker. So, the route is intranasal. Onset is 2 to 5 minutes. Peaks at 5 to 10 minutes. Indication is for PSVT in hemodynamically stable patients. It is not indicated in atrial fibrillation, atrial flutter, VT, wide complex tachycardia, or in hemodynamic instability situations. So please keep that in mind. The dose is 70 milligrams intranasal spray, repeated dose permitted in selected protocols. The adverse effects is nasal irritations, rhinorrhea and sneezing, cardiovascular, transient hypotension, and bradycardia. Contraindications and precautions are baseline hypotension, severe LV dysfunction, incorrect rhythm diagnosis, and hypersensitivity to calcium channel blockers. The advantages: it is non-invasive, no IV access, short acting, early SVT terminations, and reduced ED visits. The limitations is it is ineffective in AF, flutter, requires accurate diagnosis, not for unsuitable patients, and it was an investigational drug. Now the regulatory status is as of 2024-25, it is now FDA approved. It is not yet routinely practiced clinically worldwide, but it is expected to be available in 2026 in India. So it is a pipeline drug, but it is not a bedside ICU therapy yet. Now the ICU relevance is you won't be spraying this in the ICU, but it represents a shift towards anti-arrhythmia care. Because similar concepts will hit AF control rate, VT suppression, migraine, and panic physiology. So expect future intranasal cardiac drugs also. So that is why I wanted to put this. Please know about it. So this is about BLS, ACLS, and ECGs. Now, any queries are there, please put it in the chat box. I will answer everything towards the end, or I will put it in the WhatsApp group itself. So after this, we have just one more topic, that is on focus. So we will just take a 2-minute break and then we will go ahead with the focus and echocardiography. So focus like ECGs will be mainly an interactive session, because this is more, I need to know more about your depth of understanding rather than mine. So we'll just take a 2-minute break and then we will go ahead with this. With this, we will be completing the sessions regarding to the practical discussion. So we'll go into the last discussion for the day. So it will be on focus and echocardiography. So from an exam perspective, the areas they are likely to cover are on protocols. So they can ask you about blues, rush, falls, or sesame. So you'll need to know about it. Then if they have an ultrasound at the bed, in the OSCE station with the volunteer, they may ask you to evaluate, or demonstrate certain signs. So because of that, you will need to know. But now in the recent exams, in most centers, in OSCE stations, ultrasound is usually not kept because of the PNDT Act. So instead of that, they will be keeping images. So based on those images, they may ask questions and you will have to answer them. So I'll be giving more of scenarios. So I need more participation. So coming to the scenario, the first one. A young woman is transferred to the ICU from an outside hospital due to severely depressed mental status thought due to intoxication. You evaluate her intracranial pressure using ocular ultrasonography. The first question is, does this patient have intracranial pressure elevation, or is the examination indeterminate, and what is the limitations of this test? So there are three questions. So Jogendran has told yes, but yes for what? Raised ICP. Okay. Okay. So does this patient have raised ICP elevation? Yes. Okay, fine. So is this examination which they have done, is it determinate or indeterminate? Okay. ICP 57 millimeters more than 22 millimeters Hg. Okay, excellent. Actually, it is not 57, it is. Okay, yeah, that's correct. 57, 5.7 cm. No, 57. Are you sure? I think the metric doesn't seem right. It should be 5.7 millimeters. Okay, anyway. So do you feel this examination that has been done, is it okay or is it not okay? Okay, okay, excellent. So the patient does have raised ICP. Okay, so you see that this test that is being done here is an optic nerve sheath diameter. All right. So here you can see the diameter is being tested. So the distance here that is being demonstrated is 0.6. So the number cutoff that you need to know from an exam perspective is 5.7. So if it is more than 5.7, it correlates with an ICP of more than 22. So that is number one. Number two is whether the test is determinate or not. So the important thing is when you do an ultrasonography, ocular sonography, you need to make sure that the anterior chamber, that is the lens, the anterior chamber, the eyeball, the optic disc, all are in a same axis, or at least near to the same axis. So when this is in the same axis is when you can say that the examination is determinate. Because many a times when you keep the probe position altered, the images will not be adequate. So because of that, the measuring of your optic nerve sheath will not be true. All right. So that is an important thing that you need to keep in mind. So the rest of the things is something you know already. So you measure the optic nerve 3 mm behind the optic disc. So all right. So that is the way of assessment. So identify the procedure being done. And here there are a few waveforms. Here PSV, EDV and MFV, what do those denote, and what are the indications in ICU practice? Superb. Okay. See, thing is, you mentioned it is a transcranial Doppler. Okay, that is okay. But I'm just asking the waveforms that the terminology related to that. See, here you are showing normal flow is what one person has written, and dash and vasospasm. Vasospasm in this, it is less likely to be there because here you can see that the mean needs to be more than 120. Sorry, the peak velocity and the mean that needs to be calculated has to be high. So that's more on the lower side. Here the numericals are present. So even if it is not calculated, it is not a problem. And here also they given the values. So here you can see the peak systolic velocity. Here you can see the end diastolic velocity, and here you can see the mean flow velocity. So the indications, one is vasospasm monitoring. Fine. What are the other three indications then? Excellent. Very good. Flow reversal, raised ICP, midline shift. Excellent. So that is what that's what they'll expect. So detection of vasospasm, raised intracranial pressure identification, assess for midline shift, and detect cerebral circulatory arrest. So here you are in patients with SAH, especially involved in the MCA territory. So you can assess the MCA mean flow velocities. So you need to know that the lower cutoff is 120. Then for moderate it is 160 and severe it is more than 200. All right. So you need to know about Lindygaard ratio. So if these images are asked, invariably they're likely to go about that. So it is the mean velocity in the MCA divided by the mean velocity in the ipsilateral extracranial ICA. So these words need to be specific. That is what they will ask. So high velocities in the MCA may be due to hyperemia or vasospasm. So the Lindygaard ratio helps to distinguish these conditions. So if it is less than 3, it is hyperemia. If it is more than 3, it is vasospasm. 3 to 6 is mild and more than 6 is severe. So another thing, when they keep these waveforms, they may ask you about the formula for mean flow velocity. It is peak systolic plus end diastolic into 2 by 3. Then here you can see for assessment of midline shift. So from the temporal bone till the third ventricle of one side, the length is taken, distance is calculated, and similarly in the contralateral side, temporal bone till the third ventricle, the distance is calculated. So based on that, the midline shift can be calculated, the amount of midline shift. Then for patients who are developing cerebral circulatory arrest, TCD serves as a very good waveform. So you can see that the waveform variations will slowly occur. That is, there can be diastolic blunting, then diastolic reversal, then the decrease in the amplitude of your systolic waves. Then for assessment of raised ICP, there is something called the pulsatility index. So it goes by the formula of peak systolic velocity minus end diastolic velocity divided by the mean velocity. So based on the above formula, the score of 2.3 correlates with an ICP of 22. Whereas if it is less than 1.2, the ICP is around 12. So that is something you need to keep in mind. So what is the procedure that is being done over here, and what is the name of the trial related to its use, and what was its conclusion? Okay, excellent. So it is a percutaneous tracheostomy. It is an ultrasound guided tracheostomy. It is the trial associated, it's not a Trackman or a set point, it is Trackus. So 4 people have told it correctly. Excellent on that. So ultrasound guided percutaneous dilatation tracheostomy versus bronchoscopy guided percutaneous dilatation tracheostomy in critically ill patients. Ultrasound guided PCT was non-inferior to bronchoscopy guided PCT in mechanically ventilated patients in the ICU. So this is the one you need to keep in mind. All right, very good. So an 18-year-old male was admitted as a case of road traffic accident. In view of severe hypoxia, he was intubated and mechanically ventilated. 10 minutes post-intubation, he developed hemodynamic instability. Lung ultrasound was done, which revealed the following findings. Okay. So the diagnosis, Okay. So two people have told lung point. Say lung point. Okay, fine. Excellent. It's a pneumothorax. So superb. So the important thing for a pneumothorax is you need to look for four things. So there was a famous study that had come in 2014 regarding ultrasound, lung ultrasound in ICU. And for assessment of pneumothorax, when you look into these four parameters, that is absence of lung sliding, absence of B lines, absence of lung pulse, and presence of lung point, the sensitivity and specificity goes as high as 95 to 100%. So in the exam, when they ask, these are the four things you will have to commit in relation to the presence of a pneumothorax. So you are called to the medical ICU to assess the cause for hypoxic respiratory failure in a patient with fever and thrombocytopenia. And initial lab tests revealed dengue NS1 antigen to be positive. You perform a lung ultrasound and see this finding. Diagnosis. Excellent. So the volume of assessment is you check the distance between the visceral pleura and the parietal pleura and you multiply it into 20. All right. So the view needs to be taken as a transverse view at the posterior axillary line. Now, what is this assessment formula called? Excellent. It's Blallick's formula. All right. So important pleural effusion findings that you need to know. One is the spine sign. So in pleural effusion, sound waves can pass through the pleural fluid, allowing the spine to be seen above the diaphragm. All right. Then you have the jellyfish sign. When consolidated lung is seen floating in the pleural effusion, then you have a sinusoid sign. The parietal and the visceral pleura moving closer and further apart with each respiration. Then you have the quad sign. The pleural effusion has an anechoic appearance delineated by the pleural line, lung line, and the rib shadows. Then you have something called the plankton sign that is seen in exudative effusions. You see effusion with swirling hyperechoic debris. Then you have something called the hematocrit sign, that is echogenic sedimentation of material in pleural effusion, most commonly due to hemothorax, but can occur in exudative effusions also. So the next question, you are called to the neuro ICU to assess a case of varicella zoster meningoencephalitis who was on ventilated support for 10 days and has now improved neurologically and hemodynamically stable with no fever and resolving inflammatory markers. You perform a lung ultrasound and find that the lung ultrasound score is 21. So question number one is, how many areas do you need to assess? What are the landmark points? What are the grading or severity? And how will you interpret this and proceed further? So we'll go with question number one. Okay, 6. 6 on each side. 12, 12. Okay. Excellent. Next. Landmark points. Okay, it's okay, no problem. How will you grade the severity? Superb. I think two people have answered the landmark points perfectly. Okay, fine. Okay. So the lung ultrasound score was 21. So how will you interpret this? Twelve into 3 is equal to 36, more than 17. Okay. Okay, fine. Fine, we'll go ahead. So, like you all said, this was okay. So you will have to take four areas into consideration. That is the parasternal line, the anterior axillary, the posterior axillary, and the paravertebral line. And just at the level below the fourth intercostal space, you take a imaginary line. That will be the horizontal transverse intersection. So that is the landmarks you will have to assess. So the total severity score will be 36. So the one I was actually asking is about for each area how you will assess. So here you have normal, then you have mild to moderate interstitial edema, that is more than 3 B lines per field. Severe interstitial edema or alveolar edema, that is coalescent or B3, and consolidation. So the study by Sommer et al. Showed that a lung ultrasound score less than 13 at the end of an SPT is predictive of extubation success. On the other side, lung ultrasound score more than 17 is highly predictive of post-extubation distress and extubation failure. So most of you have answered this very well. Excellent. Okay, fine. So Jaydeep has answered 0, 1, 2, and 3. Yeah, that's correct. That is what I had actually expected. So now you are called again to the neuro ICU to assess a similar case of varicella zoster meningoencephalitis who was on ventilatory support for 14 days and now has improved neurologically and is hemodynamically stable with no fever and resolving inflammatory markers. So you perform a lung ultrasound and find that the lung ultrasound score is 9. The patient is on a pressure support ventilation mode of ventilation. The neurologist says that he is unable to wean the patient for the last 4 days. So you do something, your resident does something. So what is the test that is being performed and what is the cutoff beyond which weaning failure is high likely to be present? Okay, one person has told diaphragm thickness fraction, that is correct. But cutoff beyond which weaning failure is likely to be present. Okay. Someone has told diaphragm excursion, that is not the right answer. Okay. Fine, we'll go ahead. So what is being assessed is the diaphragm thickness fraction. So diaphragm thickness fraction is the end inspirated thickness minus the end expiratory thickness by the end expiratory thickness. All right. So the linear probe is placed longitudinally between the mid axillary and the mid anterior axillary at the level of 8th to 9th intercostal. Once the diaphragm is identified, the M mode is selected and the thickness at an inspiration and end expiration is measured. All right. So as per the text guidelines and recommendations, they say more than 30% indicates that the diaphragm function is normal. 20 to 30% is a gray area. All right, less than 20% is definitive for diaphragm weakness. All right, so in the exam, if they ask, keep your answer at less than 30. But if they ask you again, is it less than 30? Then you say 20 to 30 is a gray area, but less than 20 is definitive of diaphragm weakness. All right. Then this is diaphragm excursion. The important thing about diaphragm excursion is it needs to be done in patients who are spontaneously ventilating, not in those who are assisted or controlled. So here you take the curvilinear probe and place it transversely over the anterior costal margin between the midclavicular line and the anterior axillary line. So with every breath, here you can see the diaphragm And once you put an M mode, you can see the diaphragmatic movement. So the cutoff here is 1.1 centimeter. So one of them have told it correctly, exactly. It is 1.1 centimeter. So more than that, it indicates good function. Less than that, it indicates poor function. Coming to the next question. So you are called to the nursing home for resuscitation of a 24-year-old male who sustained an RTA by road traffic accident due to skid and fall from a two-wheeler. His GCS was 14 by 15, heart rate 130, BP 90 by 50, respiratory 30. Periphery is feeble, lactate 9.5. How will you proceed with EFAST? So the main thing I want to know is what is the full form of EFAST, and the second one is these areas that you will be examining under EFAST. Okay, so EFAST means extended focus assessment with sonography for trauma. All right, that is okay. So what are the areas that you will assess in EFAST? Okay, fine, we'll go ahead. So you will assess the right upper quadrant. Here you will assess the left upper quadrant. Then you have the pelvic view, cardiac view, and then you need to assess the right and the left for lungs for pleural effusions. Excellent. That is almost most of you have answered. So here cardiac subxiphoid view. Then you have the right upper quadrant view. Here you can see that you can assess the liver and the kidneys. And here you have the Morrison's pouch, which will be there. Then in the pelvic area, you can assess for any peripelvic collections. Then in the left upper quadrant, you can assess for collections between the spleen or kidneys or between the spleen and the diaphragm. All right. The important thing in EFAST is, in addition to this, you need to assess the pleura also bilaterally. So here you can see in the left side, in the left upper quadrant, there is free float between the spleen and the diaphragm. And here you can see that there is pelvic collections that is present in a female patient. So 50-year-old male admitted with a community acquired pneumonia, intubated, sedated, and paralyzed in view of severe respiratory distress. Developed hypertension on day 5 of ICU. You perform the following scan. So what is being measured? What is the formula for calculation? Cutoff beyond which patient is fluid responsive? And what is the other test similar to this in this different subset of patient? Okay. Excellent. So most of you know this is IVC distensibility that is being assessed because the patient is paralyzed. If the patient is on spontaneous ventilation, it will be a IVC collapsibility index. All right. So the formula for calculation is the IVC diameter at maximum and the IVC minimum divided by the IVC minimum. All right. So that is an important denominator formula you need to keep in mind, because for collapsibility, the denominator is IVC max. All right. The cutoff beyond which the fluid is between beyond which the patient is fluid responsive is if it is more than 18% for distensibility. For collapsibility, as per few studies, they are told 43%, but in most of the current recommendations, they say more than 50%. So what is the other similar test which is done with this different subset of patients? That is IVC collapsibility index. That is in patients who are spontaneously ventilated. So IVC collapsibility cutoff is 50, distensibility is 18. So the operator is typically advised to measure the IVC diameter 1 to 2 centimeters from the cavo-atrial junction, avoiding the hepatic vein. So sometimes some examiners may be tempted to ask this IVC diameter collapsibility index and estimation of your CVP. So if the IVC diameter is more than 2 and the inspiratory collapse is very minimal, then the CVP is likely to be 15 to 20. Whereas if there is dilated hepatic veins and there is no collapse, then CVP is more than 20. Whereas if it is more than 2 and there is less than 50%, but it is more than minimal, then it can be between 10 to 15. And if the IVC diameter is more than 2 and the collapsibility is more than 50, then the CVP is likely to be between 5 to 10. Whereas if the IVC diameter is less than 2 and the collapsibility is more than 50, then the CVP is likely to be 0 to 5. So from an exam perspective, when you read about hemodynamic monitoring, please do remember about this. This is likely to be asked. So how will you assess cardiac output assessment using LVOT velocity time integral assessment? It can be very brief. We don't have to go in depth. We'll have a small discussion on that also because they will definitely ask you to demonstrate it at the bedside. If the machine is not there, they will ask you to draw it and show. Okay. So I think few of them have answered. So we will go ahead. So for measuring cardiac output, first thing is you need to calculate the LVOT area. So you need to keep it in a parasternal long axis view, zoom into the LVOT, measure the LVOT diameter in centimeters, and calculate the LVOT area using the area of a circle formula. So LVOT is pi r square by 2 since you are taking the diameter. So since you are taking the diameter, it is diameter by 2 the whole square. All right. So for calculating the LVOT VTI, you need to take an apical 5-chamber view, place the pulse wave Doppler gate at the LVOT, activate the pulse wave Doppler, trace around the ejection wave, and record the VTA in centimeters. All right. So that will give you the velocity time integral. So once you calculate the LVOT area and the LVOT VTI, you will be able to just calculate the stroke volume. But for calculation of the cardiac output, you need to multiply it by the heart rate also. So this is one thing which many of us miss in the exam. So please be aware of it. So this is almost similar to what I had just discussed. Get a parasternal long axis, measure LVOT diameter, then get an apical 5-chamber view and place a pulse wave Doppler at the LVOT. And then put the Doppler mode, then you will be able to get the velocity time integral. So you need to calculate that. So what are the limitations of LVOT VTA assessment? Arrhythmias, valve anatomy dependent, observer. Okay. Anything else? Fine. So one is lack of continuous monitoring ability because it is a little laborious process. Serial TT monitoring is laborious and time consuming. Presence of conditions limiting interpretation of measures of fluid responsiveness. One is heart failure, that is LV, RV or diastolic failures. Heart failure with preserved ejection fraction, that is diastolic heart failure. Valvular conditions, like you said, arrhythmias and pericardial diseases. So in any of these conditions, assessment of fluid responsiveness becomes invalid because of the high chances of variations. 72-year-old patient admitted with progressive breathlessness and decrease in urine output over the last 5 days. She had a history of hypertension OSA on BiPAP support and recently on LTOT therapy. Admission SpO2 and room air was 88%. Initial labs revealed a creatinine of 2.5. Baseline check 3 months ago was 0.8. Urine complete was normal. There was no evidence of HUN or other features of sepsis. CECT was done, which revealed no pulmonary embolism. Echo revealed severe TR, RVH, TAPC of 0.9. LV diastolic dysfunction grade 1. IVC was 2.5 centimeters with no respiratory variations. Any focused assessment you would like to do in this patient? Okay, so answer is correct. It is Vexes. Now Anshul has mentioned it as DVT. Now here the TAPC is 0.9. Okay, so that might have been very tempting to go ahead with the thought process of an RV dysfunction. But here in CECT, there is no pulmonary embolism per se. So DVT assessment for this AKI is an unlikely answer. So answer is Vexes. All right. So Vex's assessment, I assume that you all know about it. Please memorize these diagrams before the exam. So in a normal study, usually the systolic will be more than the diastolic when you assess for hepatic Doppler, vein Doppler. In mild abnormal, the systolic will be smaller than the diastolic. In severe abnormal, there will be S-wave reversal. All right. In portal vein, you need to assess the pulsatility index. The numbers you need to keep in mind is 30 and 50. So less than 30 is normal, 30 to 50 is mild abnormal, and more than 50 is severely abnormal. Then coming to renal vein Doppler, normal is you have a normal monophasic flow. In mild abnormal, you will have biphasic flow with the systolic and diastolic pattern. In severe abnormal, there will be only diastolic. The systolic will be absent. So for grading, grade 0 is IVC less than 2. We don't need to work up further. If it is grade 1, IVC more than 2 and any combo of normal to mild. For grade 2, IVC more than 2 and 1 severely abnormal. And grade 2 is IVC more than 2 and 2 or more abnormal. All right. What is modified Vexus? Superb. Excellent. So that's the answer. So this article came up in 2025. So the original Vexus renal Doppler was mandatory, but in modified it is now become optional and is often omitted. So the rigid grading was there previously. With modified, it is a pattern-based interpretation. All veins were required. The key veins, that is hepatic and the portal, are sufficient. So the main purpose was research grade level assessment, but now modified Vexus is ICU workflow friendly kind of an assessment. So how modified Vexus is actually used at the bedside is you see IVC dilated, you see the hepatic vein where there is S is less than D, or there is reversal, or portal vein pulsatility is more than 50%. Then it indicates clinically significant congestion. So you need to stop fluids, consider decongestion using diuretics, ultrafiltration, afterload reduction, and reassess Doppler dynamically. So AKI assessment for post-renal etiologies. Here you can see there is a catheter block, and here you can see hydronephrosis that is present. This is just images just for your interest. Very less likely to be kept in exams, but you need to know about it. So this is one area I want you all to know about. A 40-year-old male was admitted with the left lower limb cellulitis and shock and was found to have AK. So during morning rounds, there is a debate as to whether or not the patient is likely to require dialysis. Is there any modality of focus that can be used to identify this possibility? Superb. So it's renal resistive index. So it reflects the interaction between the renal perfusion pressure, arterial compliance, and the venous congestion. So it is a Doppler ultrasound measurement used to assess the renal vascular resistance, providing insight into the kidney function and perfusion. The formula goes as peak systolic velocity minus end diastolic velocity divided by the peak systolic velocity. 0.5 to 0.7 is normal. More than 0.7 is early renal stress. More than 0.74 is high AK risk. And more than 0.8 indicates poor AK with poor prognosis. So higher levels are associated with worse outcomes. So it can indicate persistent AK, dialysis dependence, and mortality. So it evaluates renal perfusion and monitors response to fluids and vasopressors. And in post-renal transplant patients, it helps to monitor for graft rejection. So the factors that influence RRI are important. The systemic BP. Higher BP is associated with higher RRI. Volume status, hypovolemia and hypovolemia and edema both increase RRI, and heart rate and rhythm. Tachycardia or arrhythmias affect readings. Another thing is it is operator dependent, almost similar to VEXAS and VTA assessment. So another thing I want to mainly emphasize here is initial time when RRI came into practice, it was being a big notion that it can help to differentiate renal and pre-renal etiologies. Now, this is false in modern ICU practice. RRI cannot reliably distinguish between renal and pre-renal because it is influenced by systemic hemodynamics, not purely by renal vascular resistance. So clinical studies show modest predictive value for AK but limited diagnostic specificity. Multiple confounders are there: heart rate, sepsis, ventilator settings, which alter the RRI independent of the intrinsic kidney pathology. So this is one thing that you need to keep in mind. Please take it as a take-home message. So with relation to gallbladder pathologies, here you can see gallstone with sludge with mild gallbladder wall thickening. The wall thickening should be more than 3 mm with mild pericholecystic fluid for a diagnosis of acute calculus cholecystitis. So that is one thing you need to keep in mind. So coming to echocardiography, the areas they are likely to ask are if they have an ultrasound machine at the bed at the OSCE station with the volunteer, they can ask you about the basic views. So any idea what are the basic TT views? Come on. Think most of you would be doing ultrasound on a regular basis. So these are like, the basics. Superb. Excellent, excellent. So you need to know about it. Parasternal, apical, subcostal, and suprasternal views. So they may keep an image of a parasternal view and ask you to elicit the anatomy. So here you have the RV, LV, LA, aortic valve, and then the mitral valve and the pericardium. So these are the structures that you need to know about. Similarly, for parasternal short axis view, you need to keep the probe marker towards the left shoulder. So that way you will be able to assess the structures. So you see the LV and the RV. The important thing is for assessment of the LV function, you need to keep the echo probe at the mid papillary level. That is when you will be able to get a clear assessment. Then apical four-chamber view. That is, the transducer position is kept at the apex of the heart and it is pointed towards the left shoulder. So here you can see the LA, mitral valve, left ventricle. Here the RA, tricuspid valve, and the RV. Then you have the subcostal four-chamber. Similarly, you will be able to see the LA, RA, mitral valve. Here it's not much visible. The tricuspid, RV, and the LV. And the septum is also visualized. So for assessment of ejection fraction, you have the qualitative assessment, that is the subjective eyeballing. Then for quantitative, you can go with EPSS. This is the one which is likely to be asked in the exam. Then assessment of ejection fraction using M mode, fractional shortening and fractional area change. These two are less likely to be asked, but this one is very, very important. So for qualitative assessment, you can have a hyperdynamic LV where the EF is more than 70%, as seen at sepsis, or you can have a normal LV function, as you can see here, or a severe LV dysfunction. So you just observe the walls of the left ventricle. Are they pulling in evenly, or they are pulling in too much or not enough? So observe the mitral valve function, how close it comes to the septum. The closer it comes, the better the function. Then in a parasternal short axis, view it at the mid-papillary level. So observe the cardiac muscles in a similar function as the parasternal long axis. Ensure that all the sides of the wall are moving inward equally. So to assist with this, you may place the finger in the center of the ventricle and watch the wall contractility. So this will make the hyperdynamic or hyperdynamic regions stand out more. So what is this test that is being done over here? Okay, excellent. So you've told about EPSS. What is the full form of EPSS? E-point septal separation. Excellent. Okay, fine. So it is E-point septal separation. So it describes the distance between the anterior mitral valve leaflet to the ventricular septum in early diastole. That is the E phase. The normal is less than 7. If it is more than 1, it correlates with an EF of less than 30%. Again, between 7 to 1 is a gray area, but that denotes dysfunction. But usually 0.6 and below is taken as normal. So the pitfalls are good angles and orientation is needed. You need a normal mitral valve and non-segmental diseased LV. So these are the important pointers you need to keep in mind. So next question, what are the echo findings in pulmonary embolism? Okay, dilated RV-LV ratio more than 0.6. Okay, now what else? Super. McConnell sign, TAPC, excellent. Okay, we'll go ahead. So you have enlarged RV, flattened interventricular septum. RV-LV ratio should be more than 1. So it was 0.6 was not correct. Then non-collapsing LV. Then here you have a TAPC. So TAPC more than 1.5 centimeters is considered as abnormal. Then you have the McConnell sign. So definitely if they keep images of PE, they are likely to ask about McConnell sign. what are the findings with McConnell sign? All right. So distinct R regional RV dysfunction. So there will be mid RV free wall, akinesis, normal RV apex. All right. So the free wall will be akinetic, the RV will be normal, and the LV apex will be hyperkinetic. All right. Then the 60-60 sign. So here the TR pressure gradient is less than 60 millimeters mercury, and the pulmonary acceleration time is less than 60 milliseconds. So the tricuspid regurgitation pressure gradient can be assessed by keeping the pulse wave Doppler at the level of the tricuspid valve. So that will help you in identifying the gradient. For pulmonary acceleration time, you need to keep it in parasternal short axis, pulse wave mode, align the Doppler with the flow. The thing is, you need to keep this parasternal short axis at little high up at the level of the second to third intercostal space. So that's when you will be able to visualize this kind of an image. All right. So once you are able to get the view of the pulmonary artery, then you can place the pulse wave Doppler over it. So, and based on that, you can assess the velocities. Identify the abnormality and please mention what pethotrail means. Okay, okay, fine. There is an RV clot. So pethotrail was one of them have told it correctly. Tenecteplase plus heparin in intermediate risk P. So what was the outcome? And what was the harm that occurred? Excellent, superb. So thing is, it had hemodynamics improved, that is a decrease in shock or collapse, but there was an increased risk of intracranial hemorrhage, especially in elderly patients. All right, so that is the significant part of this. So identify the image here. Superb. Okay, it's a tamponade. It's effusion which has gone into tamponade. So any finding that you can find over here that specifically tells, yeah, exactly, there is an RV collapse that you can see. Superb. So I think most of you have got it well. So the cardiac tamponade features are plethoric IVC, more than 2.1 centimeters, less than 50% collapsibility. RA systolic collapse is the earliest sign. All right. Then you have RV diastolic collapse. How you can identify it is by use of your M mode. All right. So in the M mode, with every contraction, you can see that the RV diastole, during RV diastole, there is a collapse that is being present. Another thing you can identify is mitral flow variations. So mitral flow variation more than 25%, as you can see over here, is also indicative of a cardiac tamponade. So that is also another finding that you need to keep in mind. So RV systolic collapse, plethoric IVC, RV diastolic collapse, and mitral valve flow variations more than 25%. So then for assessment of diastolic dysfunction, I'm not going to go more like question based. I think most of you know about it. So you need to assess the mitral inflow and you need to assess the tissue Doppler. So mitral inflow measures the blood flow coming to the left ventricle and the pulse gate is placed at the mitral valve tips. So you can assess the early flow and the atrial contraction. So normally it should be less than 8 in a normal situation. If it is impaired, it will be, sorry, normally it should be more than 0.8. Whereas in grade 1, it will be less than 0.8. In pseudo-normal, it will be again normal. But here you can see that the diastolic time will be reduced. And you see that the E by E prime will be increased. Now, how the E prime is calculated is based on the tissue Doppler. So the tissue Doppler gate is placed at the septal annulus. So you will get a negative deflection that will be calculated. The first negative deflection will be your E prime that needs to be calculated. So in normal situations, the E prime is more than 8 centimeters per second. And the capital E by the E prime is less than 8. So if this E by E prime is 8 to 15, it indicates a grade 2 dysfunction. So that is considered as significant because there is a lot of impaired relaxation of the left ventricle. And if it is more than 15, this E by E prime, then it indicates diastolic heart failure. So what is 6-point compression ultrasound? Yes, it is done for DVT. In 4-point, you assess the femorals and you assess the popliteals. In 6-point, what is the other area that you will assess? Excellent, superb. It is mid thigh. So you need to assess the mid femoral area. Okay, superb. So coming to the last part of the talk. So these are the 4 important protocols you need to keep in mind. Most of you would know about it, but I'm just going to revise through this. So blue protocol is assessment of hypoxic respiratory failure. So the nomenclature is A profile where anterior lung sliding is there. So then with A lines. A dash is A profile with no lung slide. B profile is anterior lung sliding with lung rockets. B dash is B profile with no lung sliding. C profile is anterior lung consolidation with thickened irregular pleura, and A by P is half A profile at one lung and half B profile at the other lung. And PLAPS is posterior lateral alveolar plus or minus pleural syndrome. So these are the important nomenclatures you need to keep in mind. So lung sliding, you need to assess if it is present or absent. If it is present and there is B profile, it is pulmonary edema. If it is present and it is an A profile, you assess for sequential venous analysis. If there is a thrombosed vein, there is a high likelihood it is a pulmonary embolism. Whereas if it is a free vein, you need to assess the PLAPS point. So if it is positive, it indicates a pneumonia. If it is negative, then it indicates a COPD or an asthma. If lung sliding, if it is either A by B profile or a C profile, it indicates a pneumonia. Whereas if lung sliding is absent, it is a B dash profile, it is a pneumonia. Whereas if it is an A dash profile, you need to assess if it is a lung point is present. If it is present, it is a pneumothorax. Whereas if it is negative, then you need to look for other diagnostic modalities. Very, very commonly asked question in the exam, especially with regard to lung ultrasound, is PLAPS. They will ask you what is the full form of PLAPS, and the second is how do you perform PLAPS and how the anatomical location for PLAPS. All right. So you before the exam, please practice it at the bedside. So 2 hands are applied as follows. First on the right side of the chest, the left upper little hand is placed just before the clavicle and fingertips over the sternum. The upper point is located at the base of the second and third fingers. By placing the right hand immediately below the upper hand, the fingers are placed next to each other. The lower point is identified towards the middle of the palm. All right. So the two hands are applied as follows. The first is on the right side of the chest. The upper, that is the left hand, the little finger is placed just below the clavicle and the fingertips are all placed over the sternum. The upper point is located at the base of the second and third fingers. By placing the right hand immediately below the upper hand, the fingers are placed next to each other and the lower point is located at the mid palm. All right. The Plapp's point lies at the intersection of the posterior continuation of this lower point and the posterior axillary line. All right. So once you get this point, the posterior continuation where it meets the posterior axillary line is taken as the Plapp's point. All right. So next is about the false protocol. It is assessment of circulatory failure. So first you rule out obstructive shock. So you do a simple cardiac sonography, assess for pericardial tamponade and RV dilatation. Then you do a blue protocol, assess for pneumothorax. Once you've ruled it out, you assess for cardiogenic shock. You go with the blue protocol, assess for pulmonary edema. Then rule out hypovolemic shock. That is, you have an A profile. You correct the parameters of shock under fluid administration. Then with fluid administration, if the patient turns out to be still hypotensive and eventually starts to develop a B profile, then a patient is likely to develop a distributive shock, which is likely to be a septic shock. All right. So in false protocol, first assess for obstructive shock, then cardiogenic shock, hypovolemic shock, and then distributive shock. Then coming to the rush protocol, that is for shock evaluation. For pump, you need to look for LV function, RV function, and pericardial effusion. In the tanks, you need to assess for fullness, that is IVC. You need to assess for leak. So you need to do an ultrasound thorax to assess for effusion and abdomen for assessment of ascites and compromise of the tank, that is you need to assess for pneumothorax. Then in pipes, you need to assess for either rupture or obstruction. Under rupture, you need to assess for aortic dissection. So aortic root dilatation more than 3.8 centimeters or a presence or an intimal flap or presence of a abdominal aortic aneurysm. That is a supra or a periumbilical aneurysm more than 3 centimeters. Under obstruction, you need to assess for a DVT. So these are the things that you will need to assess for shock evaluation. Sesame protocol is sequential echo scanning assessment for the mechanism of origin of severe shock of indistinct cause. So this is usually done in the cardiac arrest scenario. So the important things that you need to keep in mind is you need to keep your probe as a curvilinear and you need to keep it fixed at 8.5 centimeters. So as the massage is ongoing, you will have very limited time to assess the patient. So you need to keep a fixed areas that need to be assessed in mind. So first you need to assess whether there is a pneumothorax as a likely cause of arrest. So you assess for an A- profile. If it is not there, then it is likely to be an A profile. That means the patient is clear for fluid therapy. So if the patient you are suspecting likely to be hypovolemic, then you can administer fluids. Then you come to the legs. You do a DVT and assess for pulmonary embolism as the likely cause. So from the lung, you go down, then you slowly go up. Then you assess the abdomen. So you assess for bleeding as the cause of arrest. So you can do an ultrasound abdomen and assess for free fluid. Then once you done that, you again come up and assess for pericardial effusion. So you keep it in the subcostal view and assess for that. Once you've ruled out all this, then you can assess for the cardiac function. The important thing is for the cardiac function, they ask to use the curvilinear probe itself because it is not a matter of precision assessment. It is to assess for any abnormalities which has caused this problem. So again, just emphasizing it, you need to keep a curvilinear probe, keep it at a depth of 8.5 centimeters. You start with the lungs for pneumothorax assessment by assessing for A profile. If A dash profile is not there, then you have an A profile, then you are confident for giving fluids. Then you assess the leg first, look for DVT. If DVT is negative, you come up, look at the abdomen, assess for any bleeding, any free fluid that is present. Then if nothing is there, then you come into the subcostal view, you assess for pericardial effusion if it is present. Then if nothing fits in, then you do a cardiac echo using the curvilinear probe itself. The main thing is you are not going to assess for the exact view. You are going to just assess for any abnormality if it is present or not. So that you can assess with the curvilinear probe itself. So this is about Sesame protocol. So with this, I've come to the end of the talk. So with regard to the questions that was asked, I think there was one question that was asked initially in quality indicators. So why the multiplication factor is in thousands instead of 100 in some rates? Okay, so thing is, especially for infections, the thing you need to keep in mind is the risk of VAP increases with the number of days on the ventilator. That is number one. So that is why we count the number of ventilator days, not the patients. The reason why we take 1,000 instead of 100 is these events don't happen very often. They are very, very uncommon events. So the numbers that you are going to obtain every month is going to be very less. So when you multiply them by 100, when you multiply them by 1,000, the numbers are readable and comparable. So that is the reason why we usually take 1,000 as the multiplication factor rather than 100. And the other thing is, as per the CDC guidelines for in relation to infection control assessment and surveillance, they say to go with 1,000. All right. So that is the reason why we go with 1,000 rather than 100. All right. So I hope that is clear. So any more questions more than this, please let me know in the WhatsApp chat. I'll be happy to answer. I hope all these discussions were very helpful. So if anything else is there, any queries is there, please let me know. I'll be happy to answer. Thank you very much.